Good afternoon. This is Dr. John Bennett, broadcasting from Miami. Today, we have the pleasure of having Yannick Beaulieau, an intensivist from Montreal, Canada. He's going to tell us about his wonderful platform for remote mentoring called Reacts. This is part of the ACNS online conference for use for neurosurgical education. And I'll let Yannick basically run the show. Hello, Yannick.
Hello, John. How are you today?
Very good. I'm glad to have you back.
Thank you. Nice. It's a pleasure to be with you today.
Okay. Do you want to just basically tell a little bit about yourself, about your platform, and you can launch into a demonstration?
Excellent. So what I'll do is start by launching my PowerPoint, and I'll introduce the platform, show a couple of videos that will be in the PowerPoint, and then I'll go and share my screen showing the application itself. Okay, so I'm going to start by sharing my PowerPoint, which is, I just have to fire it up in the background here. And here we go. And I'll put this full screen like this. Okay, so I'm, as you mentioned, I'm a cardiologist and critical care physician from Montreal. I'm practicing at the Hôpital du Sacré-Cœur de Montréal. I also practice at the Montreal Heart Institute, where we cover the intensive care units. And I'm the president and CEO of a company called Innovative Imaging Technologies. So I'm the founder of the company and started the platform called Reacts 4 years ago. And the idea behind Reacts was really to bring something that would go one step further in terms of bringing a way to very dynamically and very collaboratively have a way to connect people anywhere throughout the world beyond just the video conferencing type of platform. So, in fact, the word Reacts stands for Remote Education, Augmented Communication, Training, and Supervision. So Reacts, in fact, really needs to be seen as a digital collaborative platform. And we brought the term called hyperpresence. So we go beyond the typical telepresence experience to bring way more to the interactive process, and we'll see how this comes to life. So we call that hyperpresence. So really the platform is pretty simple, flexible, intuitive, and it's geared not just toward talking and seeing each other, but toward pushing collaboration, supervision, education, mentorship, and remote assistance. So as I mentioned, we're based in Montreal. I have about 20 employees right now. Some of them are temporary, some of them are permanent. And we have quite a team really built around a core of experts. And our goal is really to enhance remote interaction through multimedia digital collaboration. So we designed the platform from the start as we wanted to make this clearly focused on the medical world to be compliant with the various types of certification. And the different countries have different specifications. The one in the United States called HIPAA is one of the strictest security compliance for the standards in the industry, and we're compliant with this standard and other standards from other countries. So the idea behind Reacts, before we jump into the demonstration, was really to bring together high quality video conferencing, either peer-to-peer or bringing many people to the session at the same time. We wanted to be able not only to stream one camera, like when you show your webcam and the other people see it, but we wanted to bring multiple video feeds so that a remote user can put, for example, one webcam, one laparoscopy feed, another which is the patient monitor, the other one can be the microscope used by the neurosurgeon. So the user can use multiple feeds and broadcast that to distant users so that they can see from different perspective what's happening. There is for sure application and screen sharing, as I'm doing right now with my PowerPoint. We incorporated instant messaging so that people can communicate not only live, so what we call synchronously, what is called synchronously, or asynchronously. So we may not be available live to discuss something. So by having this secure messaging where we can send files, images, videos, and share all kinds of different procedures, and it allows more flexibility. So we brought a way to have all kinds of sharing of multimedia material, images, video, 3D objects, audio files. So the idea is to be able to play with this collaboratively, superimpose stuff so that you can have, let's say, a 3D object virtual superimpose on the real one to show and guide the other user. And we'll go through that. We incorporated tools to be able to have checklists and reporting tools incorporated in the platform so that as you're doing a procedure or supervising a procedure, you can be looking at your checklist and, you know, just checking the boxes as the person does what they're supposed to do, take video or image as it goes and incorporate them in your report or checklist so that you can have everything in one, so you don't have to go to 3 different platforms to do your endeavor.
Excuse me, Yannick, you're still on the first slide. Do you still want to be on the first slide?
No, I'm still on the first slide, you said?
Yeah, you got to click on the slides.
Yeah, that's what I'm doing.
Okay. Well, try
to stop the sharing, and I'm just going to restart it.
Yeah, okay.
You tell me if you see it better, so hang out.
The bugs are plaguing us here.
So screen share, I'm going to share the PowerPoint, share, and I'm going to go full screen. So do you see now the one called on the single platform React?
Yes.
Okay. And now as I'm clicking on it, do you see the stuff appear?
It's not changing.
So what I'm going to do is I'm just going to remain in this mode like this.
Okay. Maybe sometimes you have to physically click on the slide on the column on the left. Physically click on it when you want to change.
Perfect. So let me check.
Yeah, click on another slide. Let's see if it works here.
Yeah, here I just changed. I don't know if you see it. It's called Software Solution, low cost.
No, it's still on the same one.
So look, what I'm going to do is I'm just going to share my screen instead of sharing the PowerPoint.
Okay.
Let me try that here. So entire screen, share. I think this is going to be better. So let me fire my PowerPoint. Okay, I'm going to reduce that. I'm going to go here. Okay, do you see my PowerPoint now?
Yeah. Okay, yeah.
Okay, now when I'm changing...
Yeah, excellent. Big, it's nice and big, too.
Okay, perfect. So sorry about that. So let me restart where I was here.
Sure.
So for some reason, the PowerPoint didn't change, but now you'll see everything. So I was talking about the fact that, you know, the general uses of Reacts and what you can do in one platform. So an important word here is integration, so that it integrates different functionalities. So we talked about the high quality video conferencing, streaming of multiple simultaneous feeds, application and screen sharing and instant messaging to allow synchronous and asynchronous communication, multimedia sharing in different forms, checklists and reporting tools. So we also can, as the person, if you're doing a remote assistance, you can record your session, take snapshots, you can annotate them so that when you archive them, you can go back and see what you took. Then we also incorporated innovative tools so that you can perform augmented reality and real-time image overlay, as I'll be demonstrating. So now, John, it's okay? You see the slide changing?
Yes, we can.
Okay.
I'm here too.
Okay, perfect. So here, an important point also about React is that it's a software solution, so it's based on a yearly license. So the person can use their own laptop, desktop, cameras, so off-the-shelf consumers' electronics can be used. It's a low-cost solution based on an individual license. Every user has 2 GB of cloud storage so that they can record their image, their pictures, and I'll get back to that a bit later. So when it's in multiple language, right now the platform is in French, English, Spanish, Portuguese, and Chinese. So and we'll bring a couple of more language as time goes by. So we talked about the fact it's a highly secure connection, so you have to be able to communicate. You could be at home, the person you're talking to, or you're maybe mentoring somebody who's in a hospital, in a clinic. So we really wanted to make sure that the way the security was made allowed you to go through all kinds of different firewalls and work in different scenarios. So let's talk a bit more about the features. So first, it can go from a very simple face-to-face secured video call to a multi-party session where you have, we have in our current version now up to 6 people at a time that can do a fully interactive session. And we're going to put out in fall time the webinar version where you'll be able to have up to 100 people at a time watching a session. We have incorporated a feature called the virtual pointer, so that if the user is holding their tablet or their camera, or if you have the camera, let's say, of a microscope doing a neurosurgical procedure, when you see the video feed of that microscope, you can superimpose that virtual pointer and you can interact with the other user to point at things directly in his screen on his video feed. I'm going to show a little video here, and what it will show is one of the characteristics of Reacts where you can connect multiple video feeds. So here you can see this is a screenshot of Reacts, and on top you can see there are 2 webcams and a monitor. So the remote users is having these 3 video feeds connected, and here you can see my video feed at the bottom. So if I start the video, I don't know if you're going to see it smoothly or not, but so what you see here is that at a distance I can take the video feeds of the other users, my own video feed, I can play with them, place them where I want. I can make them bigger, smaller. I can crop them. So here you see I take the patient monitor video feed, I put in the screen, I move the webcams around. So you can really do anything you want on the live video feed. So here I'm just asking the person, okay, put your hand, and I'm going to just do a simple right click on his video feed so that I can go and crop. It's kind of a zoom and crop type of feature, so I can go exactly where I want. I arrange exactly the size of the area I would like to zoom on, and then when I'm ready I just click on apply, and then I can take my pointer and say, okay, do this there, do that. So it's really a fully interactive communication. Here I'm going to show another example. This is during a cardiac surgical procedure. So how it goes is that in the OR, there are 2 cameras that shows, I would say, the general operating room from different angles, and the surgeon, the cardiac surgeon, has the camera on his head, so we can see the video feed of the head camera, and we can see 2 other video feeds. So I can play with them, move them around in the screen, and be in live collaboration with the surgeon at the same time, and whatever is happening in the OR, you can see it live from these different perspectives. So you can imagine any type of video feed connected, allowing you to do that. You can then, as we talked about, just do the simple screen sharing. So the person may be popping up a CT scan, an X-ray, an MRI, and you're looking at it live, just through the secure share application, share desktop type of application. Here I'll show you how you can use virtual guidance with 3D objects. So here what you see on the left is a real ultrasound feed from what we call an ultrasound phantom. So these little blocks where you can scan them and practice putting needles and practicing. It's in fact simulating as if you were looking at a blood vessel with ultrasound. So there's a webcam pointed at the hand of the user so that we can see what's happening with the hand. There's a video feed taken directly from the ultrasound device, and there's a webcam that just shows us the person. And in Reacts, I can go into the 3D objects section, and I can upload. We have put a couple of 3D objects in there, and anybody that has a bit of graphic artist experience can import their own 3D objects in Reacts, and I'll show you here how it's used. So at a distance, I can take my virtual probe. So here you can see a virtual ultrasound probe that appears, and I can put that virtual probe, I'm just playing with it with my mouse, I'm superimposing this on the probe, on the real probe of the other user. I make it semi-transparent, and then remotely, just by moving that virtual probe, I can tell the person what to do. So here I can take the probe and tell them, okay, come closer to me with the probe, and as I move the probe, the other user just follows what I'm doing by looking at his screen, because on his screen, the user sees the same thing. He sees his probe, the digital probe, and he just has to follow it. So you can do that virtual assistance by using virtual 3D objects, and I'll show you later how you can do the same by using real objects. So here I'm using the virtual pointer just to tell him, you know, put your needle exactly there, and I can see at the same time live what's happening, and I can see the needle going in. So I'm telling him, okay, stop, now you're in. So you can do this remote live guidance either by just using simple things like the virtual pointer, more fancy things like the 3D objects that you can really have them follow you. So again, you can see how this is completely different than what you would do during a standard video conference endeavor. Now, you can also, as you're doing the procedure, you may be interacting with someone who doesn't have a great internet connection. So the person may be taking snapshots, either video or stills. They can put annotation and send them to you. So if your internet connection is not good enough to do live, when you receive the image or video, you can look at the annotation, you can interact over it and give your guidance, put another annotation, and then send back to the person. So instead of doing live, you're doing what we could call near-time interaction. And I'll show you in a few minutes how you would be able to do that. So the idea here is that you can still have a fairly very precise collaboration, even if you're in a low bandwidth condition that may preclude you from doing a live video conferencing. So we wanted to make sure we had a solution to bring this asynchronous way of communicating to the clinician. So also, I was explaining that you can, in advance, here I made this checklist about thrombolysis and stroke. So the person may be at a distance looking at someone in an emergency room. He could be remotely connected to the emergency physician, examine the patient with the ER doc, and then as the examination takes place, they just fill up their checklist for to see if they're candidate for thrombolysis. They can see the scan at the same time and incorporate images from the scan in their checklist so that when they're done, their report is finished and they can have their NINDS scores right away and tell the clinician if they can go ahead with thrombolysis or not. So the idea is really to, again, integrate all these things together. You can also use the application for medical simulation. So you don't have to be in a live session. You could be, as I'll show you here, I'm going to have the video start. There's some audio. I don't know if you're going to hear it, but it's not pertinent anyway. So here the fellow is in the ICU. We have placed 2 webcams that you don't even see on the video. We have placed a feed that gets us the monitor of the simulator. So here you can see the screen of the computer in which the feeds are connected to Reacts. And right beside is the operator of the mannequin to have the pupils change and the blood pressure and everything. So here we can see the exact screen of Reacts where we can see the fellow as he's taking decisions. And here I'm going to skip a little bit in the video. And what you're going to see are the people that are remote. And they're just in another room on a standard computer and they can see everything the other person is doing. And they can do the assessment live. So here they're kind of using it internally just to do this assessment simulation. So the patient, the student could be at the other end of the world or could be very, very close by in the next room. So it could be used for this educational assistance. Here I'm going to show you a video that we recently did. I'm not sure how well you see it when it's streaming, but we have performed a remote ultrasound session between people that were in Calgary, Alberta, which is quite a long way from Montreal. And I was in Montreal. I took some time during my rounds, and here you see the result. So I was just covered by my colleagues as I was assisting them. So the user here are performing the bedside ultrasound. I can see their ultrasound feed. I can see their hand. And here you see I'm superimposing an image over the live feed that the trainee is showing me. And I can play with the opacity of that video feed, so that of the image, I mean, over the video feed, so they really understand what's the anatomy. Here what you're seeing is I just dragged and dropped a normal ultrasound feed at the bottom of the screen. and they can see the normal ultrasound and the live ultrasound that they're performing, so that they know what to aim for. Okay, so during the session, I can put images, videos, objects that we can just share. And here I'm telling him, open up the mitral valve so you can see it better. So you can see how I can remotely interact live exactly on what the user is doing. So here I'm going to skip a little bit in the video. So here you see I'm showing them pathological clips. So in the upper part here, we can see the live feed of the user. And at the lower end, we can see a pathological case. So when you're doing a live procedure, you can be showing cases as the user does the live procedure. Okay. So I'll show you a little bit further. So this is the setup on my end. So here you see what I'm going to be doing. What I'm doing as I'm going to stop the video, I'm taking here, it's a 3D printed probe. So I have a file of an ultrasound probe. It's just a digital file. I went, I printed it in 3D with a 3D printer. And what I'm doing now is you're going to see that I'm going to superimpose my video feed. There's a webcam here focused on this dark background. And by just decreasing the opacity of the video feed, I'll be able to place my hand over the participant's hand so that I can really have this very interactive way of showing him where to position the probe. So here you'll see, so you see that I'm putting the video feed right over his video feed. So I can show him how to do the imaging of the inferior vena cava as he's doing here. So even if we're, hundreds of kilometers from one another, I can have my own hand over his hand to show him how to position the ultrasound probe on the abdomen of the patient. So you can see here the assistance being performed. So again, this is a way to have something that's really practical, like ultrasound, that you need to have your hand on the thing to do, but remotely I leave the user to have his hands on his ultrasound machine, but I can assist the user in a very practical way, and bringing my own feeds, my own hands in his own ultrasound feed, so that we can interact together. Here I'm showing you a picture of some of my colleagues that are doing a remote assessment for ultrasound supervision with people in Haiti. So you can see the two people from Haiti here, the person from Montreal, and the video feed from the ultrasound. So they can really make sure that they teach them, they supervise them, and they help them get the correct diagnosis. They can train them just by having this remote mentorship through the platform. We recently had a session where I'm going to start the video here. I was in Montreal, and I was giving a session to ER physician from Beijing in China. So I was showing them how to use ultrasound for guidance of central venous access. So here we can see just a few pictures. So the nice thing with React is that you can use the platform to directly present in it. So instead of being a PowerPoint, you're directly showing video feeds and slides in the application. And what it allows you to do, I'm going to skip a little bit here. So it allows you to do so as you can see here, I don't know how well it comes out, but I'm using an ultrasound probe, a virtual probe, that I can move in the object, in the picture. And by moving the 3D probe and the needle, I can really show them how they should be doing the procedure. So the idea here is to be able to communicate from anywhere to anywhere in the world. I'm going to show you here a video of React that was used to broadcast a live surgery, a cardiac surgery. So about 15 cardiac surgeons from different places in the world came to attend a 2-day course on what we call the RUS procedure. And here you're going to see the surgeon is live in the OR, and there's another surgeon in the conference room that does the full interaction during the procedure. So here the anesthesiologist first shows the ultrasound image. It was a significant aortic stenosis. So he's doing this live discussion. And then now we're in the OR. So there's a camera at the head of the surgeon. And there's another camera showing overall the surgical field. So here you're going to see the setup is super simple. the webcam from that is on the head of the surgeon, and the other webcam that is at the head of the surgical field are just connected in the computer. And then there's a live broadcast which is made of these different video feeds in the conference room, so that the attendee can see live exactly what's happening. They can ask questions to the surgeon. So this allows this really straightforward telesurgery type of communication or mentorship. And they were there for 3.5 hours looking at the live surgery every step of the way. I'm going to show again, remaining in telesurgery, here a laparoscopic procedure. So it's a hemicolectomy being performed. So the video feed from the laparoscopic machine is just taken, brought to Reax in a computer, and then the person is live at a distance, can see the live video feed and interact on it, either with pointer or with his own hand, just being able to see exactly what's happening and doing some either supervision, training, or mentorship. A project was done at Centre Hospitalier Universitaire de Montréal, which is one of the biggest hospital centers in Montreal. It was used by neurosurgeons. They performed 20 procedures, both cranial procedures and procedures for the spine, and they used it for training their fellow. So here you can see, this is the chief of neurosurgery, and you can see the multiple video feed. I'm going to go to the next slide. So there's a camera which is focused on the surgical field. Another camera is showing the global area where the person is doing the surgery, and another video feed is coming from the fluoroscopy machine. So the neurosurgeon can be in his office supervising the senior fellow doing the procedure, giving training, giving live assistance. So we can see different feeds here. Other fellows can be in the room with the surgeon, and they can see exactly what's happening. And not only the surgeon doing the procedure is getting all the training and mentorship, but the people at a distance can get the education from the intervention. So they also connected the video feed from the microscope directly to React, so that the surgeon at a distance can interact on that video feed and guide the person. So they did these 20 interventions. They produced a 47 pages report on the use of React. Unfortunately, the report is in French, but it's available online, and they were super good evaluation and results from the project, of giving more autonomy to the fellow, of helping to do very comprehensive training, which is even better than when the surgeon is sitting or standing by the fellow. So the remote mentorship, even within the same hospital, provided very, very good results on both the practical and didactic aspects of the training. So as you can see, there are multiple applications in healthcare of the platform. It could be used for clinical settings, for remote consultation. It could be home care, readaptation, wound care, tele-ICU, tele-stroke. But it could also be used for remote education and supervision, for remote assistance for procedure and surgeries, and as a tool for the briefing and debriefing aspect of simulation. So what I would like to do is to show you the application itself. So John, can you tell me if you see the React screen right now? You should see blue.
Sessions, contacts, settings.
Fantastic. So now I showed you I would say the didactic part. Now let's go into the real thing. So what I have now is my React application opened up. Okay, and I'll show you first one of the very important thing in React is that you have a library. So if I click on library here, you can see my library opening up, and it's divided in categories. So on the left, you can see images, videos, 3D objects, snapshots, documents, checklists, and reports. So you could be, let's say I'm on an airplane, I'm not even online, and I fire up React. I can connect even if I'm offline, and then I can go and populate my library. So I may say, you know what, I'm going to be assisting a specific neurosurgeon to do a procedure where I need to show them schemes, pictures, images. So I can click on import new image, go on my computer, go in my folders or USB key, organize all my images by folder. So if I go here under ultrasound, I have a bunch of different images. So you just organize the information the way you want. If I want to add some videos, I'm going to go into the video section, import new video, get my training videos, organize them. You can then put 3D objects. You can put checklists, documents. So you're going to go get a bunch of PDFs or Word document that you want to share during the presentation. So once you're done with that, anytime you're in a session, you can go to your library, go pick something you put in there, and show it during the session. Remember that everything that you leave in your library is in a secured, HIPAA-compliant environment where you can transfer files, and even if you have patient data in there, it's all protected. So you also have, here's the checklist and report creator, so you can click on checklist and reports. Let's say I want to do a checklist template, create template, and then I just start here. I may say, okay, I'm going to start by adding here. So neurosurgery procedure, and then I'm like, okay, next thing I'm going to put the name of the patient. So let's type name, whoops, and then I'm going to go to the next one. Let's set the date. So you can see how you're just creating your checklist as it goes. So you could say, my next thing I'm going to say is, was prepping adequate? And then I'm going to go to the different types of answers. So radio button, one answer is yes, one answer is no. If I want, I can give points to this answer. So let's say if the prepping is adequate, it's 3 points, and if it's not adequate, it's 0. So then you can see how you just create your checklist. And then you can be going in a mode where you just practice it. So I go to the fill mode. And this is where live during a session, you would just be, typing the stuff. Okay, Joe Blow, here June 25th. And then, yes, the person did well, yes or no. So very simple, very intuitive to create your checklist or report template. So, so now let's go into a session. So if I'm going into a React session, when I'm in a session, you will see on the left side of the screen, you can find again the exact same thing that is in your library: images, video, 3D objects, so that it's simple. It's intuitive, you know where to find the information. And on the right side, you're going to see the different type of actions. So you can connect, you can start a session, you can transfer files. So one of the unique thing in React is that you can build your entire session in the application and then just fire it up and call someone. So for example, if I go to session and I'm going to go open session. So I have a bunch of different sessions here. If I go open the one I did for ultrasound guided catheter placement, let's go open that. So what it's going to do is that it's going to go get all the images, videos, and scene that I've prepared. So if I go to images, I'm going to see a bunch of images here that are images that I have put there before. If I go to videos, all the videos that I've prepared are all there. So then during a live session, I created, all kinds of scenes. The scenes are all there on the left. So I can go here on another scene, let's say like this. The minute I click on it, the scene appears, and this is all interactive. So I can pick up the 3D probe that I have placed there. I'm moving it around, as you can see. So here I can then take the needle and show, okay, I'd like you to place it there, place the probe there, move it like this. So in React, you can incorporate your images, your videos, your 3D objects, and when you're ready, you would just go to connect and then find your contact, fire up, start the meeting, and be interactive and do all of that live. Okay, so I'm just going to close that now. Sorry, I'm just going to close this meeting like this. Okay, so now I'm just going to go back to the live session, to the beginning. So let's say we want to do some interaction. Let me show you. At the bottom, you see my webcam. I'm placing my webcam here. Let's say I would like to add a second video feed. So I'm just going to take, this is a webcam. It's like a microscope pen webcam. So I'm just going to connect it in my USB port. It's really plug and play. So as I do that, my video feed appears, and I can right away take it, put it in the picture. And then here, I'm just going to do the focus. So I have my second video feed here looking at my eye, so that you can see on the left, you can see me, you can see what I'm doing with my overall webcam, which is on my computer, and you can see my other video feed. So this, I could, let's say I'm doing a recording of that. So let's say I'm going to click record. So now I'm doing a recording. I can take my pointer and talk about this point here, this, and then I could crop it. So let me do right click on that image, crop. I'm going to focus this there, apply, and then I'm going to stop the recording. So you can see how it's, drag and drop. Let me just remove that video feed. And the recording I just took, if I would like to review it right away with the user that is remote, I'm just going to open my snapshot gallery. The video I just took is here. I'm going to put it right there. Okay. And now you can see what I just recorded. So imagine that I would be a remote person and I just received the video you just did. You could annotate that video. So I could do a right click on that video, go to add a note, and then I could say, I'm going to type anything here, but here is the lesion I told you about. How should I address it? So then that comment will always remain with that video. So if I go here where there's a little page icon, when I put my mouse over it, I'm going to see the text that is associated with that video. So now if I'm a remote person, I could be interacting over that video. So I receive it in Reacts, I take it from my snapshot, I put it on my scene, and let me show you here some fancy things. One thing I can do, which is pretty cool, just before showing this to you, I'm going to show you the setup. So here I have this piece of black cardboard, very simple, and I have this camera holder. So I'm going to place my camera right here, okay? So that by doing this, I'm placing my camera and I'm going to focus it on this black piece of cardboard like this, okay? Okay. Now what I'm going to do is I'm going to take my previous video, I'm going to place it back in the screen, and by placing this webcam here, from which I'm going to change the opacity, I'm going to bring the opacity down to 58%. That's great. So now what can I do? I can put my finger, whatever I want, over the video feed of the other person and directly interact on it. So now I can say, okay, I'm taking my scalpel handle here, and I could say, here is where you have to do the cut, for example. So I can take my own hand and just interact live on the video feed of the other. So this can be done either in a live way. So if the person is doing the surgery, I can take my own tools, my own hand, interact over their feed and tell them do this, cut it like that. So very, very interactive. Or it could be asynchronous. So I could be watching the video of the other user. Now I'm going to be recording over it. So I can now, over the recording, explain this here is how you should do it. You should, point like that. And then I could say, I'm going to take my pointer, put a different color. And with the pointer, just go over the video. So now what I just did was just to record a video over the video of the other person. So here, let me show you. I'm just going to take that new video, put it here. And what you see now is the video I just recorded. So I could forward that back to my student. So even if we don't have enough internet to do a live procedure because of bandwidth issue, he can send me the video, I interact over it, I send it back. So it's what we would call near-time communication, which allows you, if you have good bandwidth, that's great, because then you can do all this live interaction. So it shows you again how the important points about Reacts that are different from other platforms are to really bring all this degree of live interaction. Let me show you something else here. I'm going to go into my images, and I'm going to go get a CT scan. So here, if I go to demo images, I'm just going to open my folder. Remember, I told you, you just upload your images. So I can go get a picture of a CT scan here. If I would like other things, I have a chest x-ray, another x-ray. And I'm going to go into my 3D objects, and I'm going to go get a 3D objects of a brain. So we just uploaded an object with an extension called OBG. So I'm going to take, the brain is here. I'm going to put it here. Let me take another one. I'm going to take a virtual scalpel and a virtual needle. Okay, so now we could have fun. I could take that 3D brain, put it here, and I can manipulate that brain the way I want. So now I can superimpose it on me, and I'm going to right-click on that brain, and I'm going to play with the opacity. Okay, here you go. So here, imagine I would like to explain to a user I'm going to put a CT scan here right beside me. And you will all see this left frontal hemorrhage here on the CT scan. So imagine I have students or people that are not that great with neurosurgery, and I want to explain them how come this is on the left side, and how is it represented. So I ask them to look at the left side of my screen so they can see the brain superimposed on my face, so they understand what's left and right. Then I tell them, here, this is the left frontal lobe. So then I can take that brain, I can move it around so they really understand well, okay, like this, and I can bring it now on the CT scan. And if I flip it around like that, and I just superimpose it on the scan, they can now understand what correlates with this area here, okay? So they can see the bleed, they can see the brain, and then I can take that brain back and move it around again, superimpose it on me, so they really understand that specific area. So now, if I would be live, I could take, these other, I will take, for example, a scalpel and a needle, okay? And here again, imagine any tool that you would want to use, and I can tell the user, okay, put the needle exactly there, and with your virtual scalpel, you can interact over their feed and tell them where they need to cut, for example. So here, as you can see, I can put, I'm going to remove the CT scan, and I can put the virtual objects directly over my own video feed. So I could say, cut here, and then put the needle here, move it like this. So, and if I want to document all of that, now I'm going into my checklist. So I'm going to take here just an example. It has nothing to do with neurosurgery, but it's an ultrasound examination checklist. So if I would do in advance my checklist, I could be pulling my checklist here, and as I'm doing the live procedure, I can fill it up. So, okay, the name of my attendee is Joe Blow, the date, then the name of the hospital. Okay, was the adjustment of gain and depth adequate? Yes. Position on the chest, it's correct. And then did he identify the structure well? Left atrium, left ventricle, right ventricle. If I want to take a snapshot of the screen, I just do so. I click on the little camera here, snapshot. And after taking the snapshot, I can put that snapshot in my checklist just like that. Okay. So now I'm building my checklist live with all my answers, my images. So again, the important name in React, as I told you before, is integration, so that you can put everything together without having to have 5 different platforms. So I think I'm going to stop there and see if John has any questions. So the idea here today was really just going to stop sharing my screen. Stop sharing. Okay. The idea was really being able to give you that feel of what React can do in terms of interaction, putting live video feeds, interacting on it, either live or asynchronously, and how this can differ from existing standard video collaboration platforms. In terms of interaction, putting live video feeds. So, John, I hope the quality of the presentation and the video feeds were okay on your end from what you...
It was excellent, and I'm sure Ike loves this platform. One quick question. Would you have someone to help mentor someone, how to operate everything and stuff?
Okay on your end from what you...
It was excellent, and I'm sure Ike loves this platform. One quick
Yannick?
question. Would you have someone to help mentor? Yeah, Ike. Operate everything. I'm playing my video. Do you have questions for Yannick, Ike?
Yes, Yannick. I'm hearing a lot of background voice. Ramesh is joined.
Playing my video. Do you have questions for Yannick, Ike?
Yes. But Ramesh has joined. I'm hearing a lot of background voice. Ramesh is joined.
Playing my video. You have questions for Yannick? Ramesh, please mute. Ramesh, please mute.
Ramesh has joined. I'm hearing a lot of background voice.
Hello?
Can you hear okay, you guys?
Yeah, John, I'm trying to fix up the camera here.
Ramesh, please mute. Ramesh, could you please mute your microphone?
Hello?
Yeah, we're getting feedback from your microphone.
Yeah, John, I'm trying to fix up the camera here.
Ramesh, please mute. Sorry about that. We're all learning this tech. We're getting feedback from your microphone.
Switch off my microphone. Okay, I will do that.
Yeah, please mute it. Mute your microphone. It's at the top of the screen.
Okay.
There's six icons. Click on the microphone. Mute it. There. Perfect. Okay. Thank you. Okay.
Yeah, Yannick. Well, Ramesh is from Charing Cross Hospital, London. Well, I just listened to your talk. You have nailed it. That's all I can say. These are the things that I have been looking for a long time. You know, Ramesh is one of the persons who is potentially can do cystonostomy. So, for example, if there is a case and I could help Ramesh or Roy or somebody or Go in China, if I have this reacts, then I'm sure I can help them without any problem because these are accomplished surgeons. And the same way, they could help me for a procedure that I am not very happy with doing myself. So, a few questions that I have for you is, we had this meeting called Virtual Reality Meets Medicine, MMVR. So, I was part of it about 10-15 years back. At that time, we had this haptic gloves where we could get a feedback by a magnetic field. We could get the feedback on your gloves as to what the object was made of.
Yep.
Now, another thing I wanted to, one of the reasons I'm visiting Calgary is that my very good friend Garnet Sutherland is there. If you don't know Garnet, but Garnet is a guy who did the first robotic neurosurgery in the world. So he developed this robot called NeuroArm, and it is in the second. He did the surgery with the NeuroArm 1. Now he has developed the NeuroArm 2. And so we are planning to collaborate with him, and then we are definitely interested in remote assistance of surgery. Now, we have to, I have picked up about 50% of what you said because I could not understand everything. You being a doctor, you probably might be sympathetic to people who are not very bright on, these kind of things. But I could understand 50%. I understand what is the potential for this. It's huge. It's really massive. So we need to sit down with John and probably have at least 4 or 5 sessions, and probably I can give you a few inputs as to what I would want in a program like this. Maybe you already have it, and it's just that I'm not understanding that you have it. Next thing is that you can tell me how. These sessions, these libraries, and the features that you have is just amazing. It's really amazing. So, do you think it's possible for you to probably give a talk to the Asian CNS? We have a meeting in Dubai. It's going to be one of the largest meetings in the world. We have 49 member countries, and the guy who's doing this meeting is Imad Kanan. So I would tell him, if you can come personally, fantastic. We'll invite you as faculty, or you can do that on a hangout. We will hang out. So
In fact, what we would do wouldn't be Google Hangout, but we would do a direct React session, so that we could be doing a live demonstration of all of that, where I could be connected, with monitors, and we interact together. So it's very, very easy to do. So we'll talk offline about that, but we could easily set up for a live. I did that in during multiple conferences, where I'm in Montreal, and you're there, and we can do a live interactive sessions with live feeds and everything.
Oh, that'll be great. So, Ramesh, are you there, Ramesh?
Yeah, he's scheduled next. You guys definitely got to get together and further this relationship. I'm sure you guys are going to go places together.
You should watch these videos for Yannick, and it's amazing. I was just thinking of telling Imad when he's holding his conference. I think it's more than a lot of boring neurosurgical lectures. This is amazing. This is, I was wishing to, when John told about Yannick, I was really planning to hear about it. and this is one tool I can really use to get cystonostomy also going, because I can ask him how is that. He can literally interact on the video, which means I put up a microsurgery from the microscope. If I put a feed, I can literally put a scalpel on that place, or I can put a drill on that place and show this is where to drill. It's amazing.
Yeah, I mean, I watched the last bit of it, and I was just awestruck. I missed the first part, so I felt that it's just out of the world kind of thing, technology, and it'd be great to have Yannick with us.
Yeah, amazing. So I'm right now in the WFNS, that Hakuna Matata group. Imad is there, so I will WhatsApp him about what's happening with this thing, and then I think we should call him to Dubai in 2018 when this meeting, our ACNS next meeting is on. I think we should call Yannick, and probably he should be one of the keynote addresses he should give on this. Probably we'll have a React session, and people should realize what's the potential of this program. I hope by that time he would have gone far way ahead too. Yeah. And I'm going to have some sessions with him and John, and then we will talk about how it works. Now I have only a very a vague idea of how it works, and I'm not very sure of how it works, but I see the potential.
Yeah, I agree. I think it's the world is getting smaller with all this technology, and you don't have to go or travel around or to go to other operating rooms to teach. You can just do it online.
Well, you know, when I heard about I was doing with cystonostomy, and I knew about Yannick's program, I thought, man, these guys got to meet. These guys got to meet.
Yeah, good idea.
Yeah. So okay, we're going to start our next session. Yannick, thank you very much.
Thank you very much, and we'll be in touch, Ipe and John. So just let me know whenever it's good for us to talk.
And congratulations on your funding too.
Okay, thanks everybody. Have a good day.
Okay, see you.
Okay, bye.
Okay, you know, Yannick or Ipe, I know you'd love that. I knew you would.
It's amazing. It's really amazing.
Yeah. You can. I think. Well, you can really teach a lot of cystonostomy to surgeons all. You know, I know people from India, and they come to Nepal. You know, they still will, but maybe you'll be able to reach them without having to go to Nepal.
Yeah, absolutely. I mean, this would be a great group for me.
Okay, let's start formally with Ramesh. Okay, I'm going to start formally, and this is going to be edited out. And okay, so let me start formally. 10, 9, 8, 7, 6. Good afternoon. This is Dr. John Bennett, broadcasting from Miami. We have another conference in the ACNS online conference of emerging trends in neurotrauma, and today we have the pleasure of having Ramesh, Dr. Ramesh, a neurosurgeon. He's currently in England, and he's going to talk about temporal craniotomy. But first, let me introduce the guest, Ipe Cherian. Hello, Ipe.
Hey, hi Ramesh, hi John. Fantastic to meet you guys.
Okay, I'm sorry I didn't mention your last name, Ramesh Nair. Ramesh Nair is in London now, I believe. So welcome, Ramesh. It's all yours.
Thank you, John. First of all, I'm extremely pleased to be here with my very close friend Ipe and enterprising person like John. And I'm not sure how many of the neurosurgeons are watching. And being a new experience for all of us, I found this platform a great one. Not only for this sort of academic meeting, but also to have between a close group of friends just to have a chat. I think this is something which I will be introducing to some of my friends. So it's good. And so I made a small presentation on the anatomy, which I find is relevant during some of the craniotomy operations. And it is not a high in-depth analysis of the anatomy, but what I would say is that this is something more technical nuances which I find useful doing many craniotomies. And as neurosurgeons, especially neurosurgical trainees, many things we take for granted, and we don't really go into this final aspects of it. And knowing those nuances and final aspects will make a difference at the end. So, as somebody said, go into the details, and the bigger picture will take care of itself. And those with careful observation will eventually will succeed in whatever they are doing. So this is my I'm just going to go on to the PowerPoint presentation I made. So John, I'm just going to press on the desktop, right? Here.
Okay, yeah, it's a screen share, yeah.
Yeah. Are you seeing my?
Okay, hold on. No, not yet.
You can see my screen. Yeah, okay.
Yeah, but not the right one. I think you're picking the wrong screen share.
Are you able to
There
see?
you go. There you go. Could you make it a little bigger? I think.
So how do I see the you and guys along with my presentation?
I think you can use your cursor to make it bigger.
Yeah, I can use it, but then how do I see that video?
There you go. There you go.
Yeah,
well,
but
you'll just be talking. You won't be seeing it. You just change.
Okay, that's fine.
Okay.
So as I mentioned, I will just talk on few aspects of the craniotomy for frontotemporal approaches, and a few things which I will mention. These will be quite useful, I think, for younger trainees, especially. They don't have to. These are all something which you pick up over the years, not when you start. And even the theme of this ACNS conference, teleconference proposed by IEP is mainly on trauma. Trauma as well as elective surgery carries a lot of frontotemporal approaches. So this anatomy is relevant to both trauma as well as elective work. And when you talk about the approach, there are many incisions which you think about when you do a frontotemporal craniotomy. This is a kind of standard incision where you put an incision behind the hairline and then go around across the midline. Are you able to see my cursor moving on my screen here?
Yes, we can see your cursor move.
Yeah, okay, excellent. So you can see the standard frontotemporal craniotomy with the incision curving around the midline and going to the opposite side, which you can extend lower down to the other side, which makes it a wide coronal incision. And these are which you use for more basal approaches. For example, skull-base tumors, you use an orbitozygomatic approach to expose the zygoma, orbital rim, and including the orbital bar, including the glabella sometimes to remove it if you really want to go basal. But often you can limit your limit your extension of your incision up to midline, maybe slightly off the midline, depending on how low the hairline is. So first thing when you position the patient, which I look for, is how low the hairline is. Fortunately, in females, the hairline is quite low, but in older men and people of my age, the height is still young, I think. So hairline is quite far back. And so, which means you have to make a bigger incision across the midline. So, but there are other incisions proposed by people like Yannick from Finland, where he does a lateral supraorbital approach, and the incision is much shorter. But it is sometimes the shorter incision risks being exposed outside the hairline. So that is one thing about the incision. The second one is to know the anatomy. When you look at a patient's head like this, you have to imagine, you have to have a 3D kind of X-ray vision. And that is a crucial thing which I think as a trainee neurosurgeon needs to learn. You need to have that 3D X-ray vision. You need to know where the parts of the brain are, where the structures are, even without opening the skin. In these days, we all use neuronavigation. But it is paramount that you don't depend on it. Even though there is a good technology, sometimes can fail you. And in many situations, especially the kind of work I do with the endoscopic approaches, endonasal approaches, even a minor inaccuracy for about a millimeter or two can land you in trouble. For example, if you are drilling near the carotid, if you're purely depending on the navigation accuracy, it can be quite risky. So what you need to know in those circumstances is your landmark, and this is the way you should learn. And so you should know where the sylvian fissure is. You should know where the motor strip is, the coronal suture is, approximately. These are all things you should learn to just do a safer surgery. For example, we all learn the surface marking for the motor strip and the Rolandic fissure. For example, this you can see on the right hand side. You can see the standard lines. You identify the nasion and the most prominent part of the occipital area, the anion, where the tocula is marked, and then a line connecting it gives you some landmarks. For example, a landmark which is a 3/4 here will and the point from there till the frontozygomatic suture will give approximately the line of the Sylvian fissure. And as 2 centimeters behind the midpoint of this line, and then connecting it to the midpoint of the zygoma will give you the Rolandic fissure. And we know that the motor strip will be right in front of it. And what I do is I palpate for the ridge, which is the you can see the frontozygomatic suture here, the ridge just behind the temporal line, where you put the cave bar hole, and if you just go down inferiorly over it, and you can feel where you can appreciate where the spinal ridges are, and that's the landmark of the Sylvian fissure. And about a 45-degree from the baseline here, if you draw a line across the skull surface, you know which direction the Sylvian fissure goes, and then you can understand where the frontal lobe is, and then also you can see the direction of the temporal lobe. So this sort of anatomy is quite pertinent for frontotemporal approaches. And about 2-3 centimeters behind this frontozygomatic suture, you have the arterion and the meeting point of these sutures. And it's important to know the anatomy of the zygoma, the root of zygoma, and it joins with the temporal bone here and also the zygomatic bone here. And also important to know, especially for basal approaches, to know the nerves that comes out from the zygomatic foramen, which is the zygomatico-temporal foramen, where the nerves comes out. So when you cut the zygomatic process, you got to make sure that you're not cutting through that foramen. And so this anatomy, these lines or Taylor-Horton lines are very important to know about, and especially when you start off, don't depend on the navigation system. The second thing is which I always look for, especially for frontotemporal craniotomies, to look at the frontal air sinus. You study the anatomy of the frontal air sinus on your CT scan, and there are different types. Some frontal sinus are ill-formed, not developed fully, so you can extend your frontal incision more medially. You may not breach the frontal air sinus. But some cases, as you see in this case, the frontal air sinus is well pneumatized, including the lateral skull wall is quite well pneumatized, and then you invariably might end up into the frontal air sinus when you do a frontal temporal craniotomy. And the reason why you have to know about the frontal air sinus is that my personal attitude is to avoid reaching the frontal air sinus if you can avoid it. For example, if you are doing a tumor attached to the inner table around the frontal bone here, if you can just skirt around the frontal air sinus, then that may be better rather than breaching it and trying to remove the tumor completely. Our traditional way of teaching is to get to the base completely and then to resect out the tumor. But it may be a little bit more struggle, but it makes a difference sometimes to avoid all the complications that are related to the frontal air sinus. There are different techniques and ways to manage the frontal air sinus breach, and my practice also has evolved over time. And these days, I try to, depending on how big the breach is, I tend to decide whether to cranialize it or whether to reconstruct the frontal air sinus, because it is an additional anatomical structure. You don't want to obliterate the frontal air sinus if you can avoid it. So there are, but some for example, here, this frontal craniotomy flap, if you move it more medially, then you might enter it. But if you know where the frontal air sinus is, you can just skirt around it. And if you're using a navigation system with a CT on the registration system, then you can mark the outline of the frontal air sinus and decide whether you have to breach it or not. Even though you have technology and other materials to seal off the leak through the dura, sometimes it makes easier to avoid any complication related to frontal air sinus. So you can see, if I open the frontal air sinus at the edge of the frontal craniotomy, I tend to preserve the mucosa and seal it off, and then use the dural sealants to avoid any leak. But if I fully enter the frontal air sinus, then I may have to obliterate the frontal air sinus. This happened yesterday when I was operating on a tuberculous cell meningioma. The frontal air sinus was fully pneumatized, and I had no other option other than to seal the ostia and to obliterate the air sinus. The two more relevant anatomic structures which I will be mentioning is the superficial temporal artery, and especially this is very relevant for vascular surgeons, and I knows about this very well, and we had a recent discussion about one of his cases. And the second one is the facial nerve. So we will talk about it in slightly more detail. And before I do that, I just want to mention some other relevant anatomy point where you operate in the frontotemporal area. One is the temporal bone. The squamous temporal bone, unlike the frontal area or the parietal area, it can be very thin. It can be paper thin, and especially when starting off with a power instrument, power-driven instruments like craniotomy or perforators. Even in old days, we all used the Hudson's brace. So if you're not careful about this anatomical peculiarity, one can put excessive force onto the squamous temporal bone, which a disastrous result, and I've seen it being happened. So that's quite important. I think that's one of the reasons why maybe the temporalis covers the bone, and where the big muscle bulk is present, the underlying bone could be thinner. So that fact. Same thing happened in the posterior fossa as well. You have a very big suboccipital muscles covering the occipital squama, and when you do a retromastoid or a suboccipital approaches, the squamous occipital bone can be quite paper thin, and one has to be very careful when putting pressure during craniotomy operations. So the incision immediately will be along the direction of the superficial temporal artery. It is my practice, and most of the neurovascular surgeon will try to avoid injuring the superficial temporal artery and to try to preserve it. And it is a good practice to try and learn this technique whenever you do this craniotomy, because this frontotemporal craniotomy is the bread and butter for a cranial surgeon, and this is a incision and approach which you do day in, day out. So every time when you do an incision like this, the natural tendency for the trainees is to just go through that lower part and then pass whatever that bleeds and then deal with it. But rather than doing that, try to identify the superficial temporal artery and preserve the branches. And this practice will be useful when you start doing vascular surgery, especially bypass operation using superficial temporal artery. The other thing which is relevant is the branch of the facial nerve which goes around the anterior part of the zygoma, along the anterior part of the your exposure towards the orbitofrontalis muscle. And we often talk about preserving the facial nerve. Why is it so important? It's because it supplies the frontalis belly, and damaging it will result in a lack of movement of your eyebrow. And especially if you're doing a bifrontal craniotomy, if you're not careful enough, you can damage both sides, and that means the forehead is completely mobile. Well, this may not be a major disadvantage, especially for older people, but it can be quite relevant, especially for younger people and female. And if you are somebody like Sean Connery, who can lift up the eyebrow, or Roger Moore can lift the eyebrow separately, then that becomes a major disadvantage. So talking about the artery just travels in front of the tragus, crosses the zygomatic arch, and then travels up and divides into an anterior branch and posterior parietal branch, and it travels along with the vein. So when you incise the scalp deeper here, the venous bleeding, you will encounter both venous bleeding as well as the arterial bleeding, and this can be identified separately, and you are able to, if you can avoid damaging the artery when trying to bipolar the vein, and that will preserve the artery for future use if you have to use it at some point. Talking about the motor branch of the facial nerve that goes along the anterior part of the zygoma, along the anterior aspect towards the frontalis belly, it travels fairly in anterior to the tragus. So when the incision goes down along the in front of the tragus, I saw earlier in Roberto's presentation about this incision, you should not be more than 1 or 1.4 centimeter from the tragus, because at the anterior you go, you might end up cutting these branches. So stay within 1 centimeter of the tragus, and there should be, and also the lower end of the incision, got to be careful that you don't cut to go deeper behind the parotid gland to avoid injury to the main trunk of the facial nerve. There is a schematic diagram again showing the complex network of the facial branches. So the branches are quite easy to understand. From the trunk, you have the main trunk, and it divides and then gives off branches to the temporal branch is the branch that goes to the orbit, the frontalis, the belly of the occipital frontalis. Then you have a zygomatic branch, and then you have a buccal branch, and the marginal mandibular, and then a cervical branch. These are the 5 branches of the facial nerve towards the face. Then you also have an auricular branch in the back, and also it supplies the posterior belly of the digastric. Again, it may not be a single nerve, it can be a multiple nerves, it can be a plexus of nerves as well, and we'll talk about how to preserve it. And the way to preserve it is knowing the anatomy of this region precisely. You need to know how the temporalis is attached, and what is the facial covering of the temporalis muscle, how is it attached to the zygomatic bone, and in what layer the nerves are, what layer the superficial temporal artery is. So this is the general schematic diagram of these branches, and this is the layers of the scalp around the region of the zygoma and the temporalis artery. So just to magnify it, I'll just go through it again. You have the temporalis muscle here, which is in this pinkish color here, and you have this white line, which is the temporal fascia. The temporal fascia is split into 2 layers, which encloses the zygomatic arch. So lower down, it encloses encloses the bone here, and below the temporalis, you have the periosteum. And but superficial to it, you have a loose areolar tissue. Then you have the temporoparietal fascia, which again is a continuation from distally, where the pericranium splits to enclose the temporalis muscle. But the temporalis fascia, which contains the temporal artery and vein, and the nerve is just located above this layer, this temporalis muscle layer. And there's a superficial part of fat, and that we will talk about it. You can see it here. So you can see again the pericranium splits. Just give me for a second. Hello?
I'm sorry, that's the wrong screen you're sharing, Ramesh.
Okay, let's see. Let me just go back to it.
Yeah, you'll get it. You'll get it.
Yeah, I'll get it. Okay, I think this was an. Able to see anything now?
No, it's the wrong screen.
How do I close this?
You've got to open the PowerPoint and leave it on your desktop.
Yeah, I left it on my desktop. I trying to.
Okay.
Okay, let me just minimize this and then go back to my PowerPoint.
Okay.
Okay, are you able to see?
There you go. We see it.
Excellent.
Okay.
So again, going back to the anatomy of the temporalis fascia, you can see the pericranium that splits into 2 layers. The outer layer, which is the deep temporal fascia, which again splits to enclose a layer of fat pad, and the the nerve you can see here, that is the frontal branch of the facial nerve. So my practice is to as you go more forward towards the orbital rim, to go deeper and deeper rather than going deeper at the start. If you want to preserve the pericranium, you can preserve it, but then deeper you go, more anterior you go deeper to that pericranial fat. So it doesn't matter even if you go deeper to this deeper layer of temporalis fascia. It might mean that you may even have to expose the temporalis muscle. That's not a big issue, but that means your nerves are safer here. And this anatomy is quite important to know how to preserve these branches. This is a sort of general direction of the nerve. Crosses the zygomatic arch, then travels more oblique fashion, and then ends up in the frontalis belly. And this distance from the lateral orbital rim is about 1.5 centimeter. So this is why once you come from the posterior aspect, as you go deeper towards your orbital rim, so your intention for this craniotomy is to expose the orbital rim, then you go deeper and deeper till you see the fat pad and then go deeper to it. And even if you have to include a layer of deep temporal fascia, thereby exposing the temporalis muscle, that is completely safe. The one other thing which I would like to mention is preserving these nerves, the supratrochlear and the supraorbital nerves. And often I've seen, especially trainees trying to just bust through everything when they try to expose the orbital rim, which is not a good practice, because these nerves have a purpose, and they carry the sensation even up to half of the vertex. So by detaching it, by damaging it, you might leave with a large area of numbness over the forehead. Even though patients may not complain about it, many will do. One way to avoid damage to the those nerves is to go deeper towards the pericranium and then go along the bone and then reflect the nerves as you reach the orbital rim. Occasionally, or not infrequently, you may find that these nerves come out through small foramens. And then you have to take special precautions to avoid stripping it off and avulsing it from the foramen. The one way you can do is to use a very tiny chisel and then break off the lower rim of that foramen, thereby releasing it. Or you can even drill it and make it thin and use a kerrison punch to open it up. And so this is what I meant. As you go deeper, you include that layer, the deep temporalis of fascia, to include the fatty layer to avoid damage to the facial nerve. And that means you will be exposing the temporalis muscle, but then you will protect those nerves. And you can see that once you reflect the scalp flap, the supraorbital and supratrochlear nerve will be stretched. And if it is really coming to a foramen, you have to expose that area and then try to dislocate that nerve so that it goes along with your the scalp flap. Again, this is another exposure from Roton's book where you expose the orbital rim here and this frontozygomatic suture, rest of the zygoma here, and you have exposed the temporalis fascia, and you can see the temporalis fascia is attached to the zygomatic bone there. The anatomy of the supraorbital and supratrochlear nerve, you don't have to know about the intraorbital anatomy, but it comes from the ophthalmic nerve along with the other branches like frontal and nasociliary. Then the ophthalmic nerve two branches goes into supraorbital nerve, which is more lateral, and more medial, and supratrochlear nerve, which is medial to that, because trochlear is medial. I believe this is the anatomy point which I want to emphasize in this talk. Let me just get back to the
okay.
My there's a lot of. Are you able to see me now?
Yeah, hold on. Let me check here.
How do I get up?
Not yet. Not yet. You got to minimize that screen like you did before.
What, the PowerPoint presentation?
Well, is that where you want to go to in PowerPoint?
Yeah, no, I finished with that PowerPoint presentation now, but I just want to get back to the video screen.
The Hangout, you can click on the green arrow again. That gets you off the screen share.
Oh, got it.
There you go. Well, man, I wish I was a student again, or a resident. It's a very valuable presentation, and really appreciate you taking out some time. And let me see if Dr. Schritt, Professor, are you there now? You can unmute if you want to meet Ramesh. I don't know. Do you know Professor Sridhar?
Yeah.
Hello.
Well, of course,
Okay.
I know him very well.
Okay, there you go. There you go.
Is that Sridhar there?
Yeah. Yes, I am. How are you, Ramesh? I've been enjoying your talk.
You've changed. You have.
Well,
I have.
just like you said, Ramesh, you just meet old friends.
Yes, it's great to meet up like this.
Oh,
Yeah.
You guys know each other
yeah,
from
I think
conferences?
Yeah, we've been meeting, I think, a very, very long time ago. We met, and I think we've not met for some time now after that.
I agree. I think it's been a long time, but you have
Yeah.
had a very
My big mustache has gone off. That's true.
Yeah, yeah. Are you back to Chennai or where are you now?
I'm back in Chennai now, and it's good. I'm back now for the last almost 8 years,
I see.
and I think Ramesh, I'm hosting the next NSI meeting in December
Are you? Oh, okay.
in Chennai, and yes, and this December, and it's a friendship meeting with the British Society of Neurosurgeons.
Oh, I see. SBNS.
So yeah, so I think it'll be a good thing. You can come along either as the British Society or the NSI member. It's up to you, or you can do both.
Well, I am in both actually. I'm a light member of NSI. Yeah.
That's great.
Excellent. Excellent.
Yeah.
Okay, very good.
Yes.
Okay, well, I'd like to thank you, Ramesh, for giving an excellent presentation, well illustrated, great illustration, and we invite you to stick around for Professor's next talk. He's going to be talking about the devastating traumatic brain injury management protocols. Correct, Professor?
Yeah, that's absolutely right. So I think I will screen
Okay,
share
let me terminate this one, and then we'll start the next one. So we have each video separate. So thank you, Ramesh.
Thanks, John. Thanks, John. It's great to see you, Sridhar.
Okay.
Yeah, see you.
Okay, we'll stop it here, and then let me give the formal introduction, Professor, and then we'll start your talk. So we have each one separate that we can give to you to put in your portfolio.
Okay.
Okay, as presenting at a conference. Professor Sridhar. Okay. Okay, the way, do you want to go over the PowerPoint to make sure you got it down right?
Yes, I have the PowerPoint right here.
Yeah, let's practice to make sure you got it.
Okay. So, I'm going to screen share. No, okay. One second. Okay, can you now see the PowerPoint?
Not quite. No, I think you picked the wrong screen to share.
Okay.
Okay. There you go. There you go. You got it. You got it. Okay. Can you advance the slide to make sure that works?
Yeah.
Okay.
Yeah.
Yes. Okay. Fine. Fine. It works.
Okay.
Okay, yeah, that's very good. It looks like you got it.
Yeah.
Okay, let me just do a formal introduction to start the video. I think you're ready.
Yeah.
So just get off the screen share by clicking on the green arrow again.
Okay. You want me to get off that?
Yeah, so I can introduce you. Yeah.
Okay.
Okay, click on that green arrow. There you go. There you go.
Yeah.
Okay, we're going to do a formal introduction and everything. We'll start. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett, televising from sunny Miami. This is one in the part of the online conference for the ACNS, the Asian Congress of Neurosurgeons. And today we have the pleasure of having Professor Sridhar, a neurosurgeon from India. He's going to talk about devastating traumatic brain injury management protocols. But first, let me introduce a distinguished guest who just gave a great hangout, Ramesh Nair. Hello, Ramesh.
Hi, John.
Could you just tell a little bit about you introduce yourself, please?
I've done. You're talking. Is Sridhar going to talk, or you want me to talk
No,
about
you're
Sridhar?
just going to introduce yourself for a professor's talk.
Okay. So I'm very delighted to see Sridhar after such a long time. I think the last time we met was probably in Srijitra when there was a skull-based and vascular conference, and we exchanged our details, and that's the last time I met Pro Sridhar. And we've been we knew each other for a long time, and we travel around the world. He traveled in the world, and it's so nice to see him. It's a very pioneering and very well-known neurosurgeon, and who has worked in many institutions, and he has developed a big institute on his own, which to his credit. And I'm really pleased to see that he's back to his hometown, Chennai.
Okay,
And
okay, very good, Dr. Nair. Okay, Professor, could you just please tell a little bit about your life and where you practice and what you're doing now
Okay.
before you start your presentation? Thank you.
Hi everybody. I'm Sridhar. I'm from Chennai, which is in the south of India. It's on the east coast. It's a seaside city and one of the four large metropolis cities of India, and it has a large population of people, as you can expect, and also of vehicles. I worked my first 25 years with the pioneering neurosurgeon of India, Professor Ramamurthy, and then I'm now working in an institute of neuroscience, which I head in a private hospital, the Global Hospital in Chennai. I've had the honor of editing a textbook of neurosurgery and a textbook of operative neurosurgery. And other than trauma, my interests are in vascular and spine and on neuro-oncology. So this is a bit about myself. I love teaching, and therefore here I am.
Okay.
Okay. So should I start my presentation?
Sure.
Okay.
There you go. Very good.
Okay. So are you able to see the screen now?
Yes, we can see the screen.
Oh, great. Okay. So my topic is on devastating traumatic brain injury. Basically, I want to introduce this concept, I'm not very sure that people understand it the way it should be understood. And therefore, once we try and understand the concept, I would like to then talk to you a little bit about the management protocols when we have a patient with a devastating traumatic brain injury. I first will take you over this patient who was a 16-year-old boy who came to us following a road traffic accident, basically from a two-wheeler. He was found unconscious on the roadside with vomiting and seizures. taken to a nearby hospital and then shifted to us after 3 hours. He was received in the ER, intubated, put on controlled ventilation. His hemodynamics was stable. There were no major other injuries. His GCS was E1 VP M2. His pupils were both dilated, 6 mm, not reacting. However, he had a cough reflex with spontaneous breathing efforts. This was his scan. Now, if you look at the scan, what is very obvious is the right-sided extradural hematoma, which is there. But what is also striking to the eye is that the supratentorial compartment and the brainstem are quite dark, and that is a significant finding in this CT scan. Now, we explained the poor prognosis with respect to the pupillary dilatation, non-reaction of pupils, as well as the CT scan finding of the hypodensity of the brainstem and the supratentorial compartment. However, the parents of the teenager wanted surgery. We did a right-sided decompressive craniectomy for the extradural and to see what could be done. But however, the patient passed away. Did not pass away, but we did a brain death declaration after 48 hours and organs were donated. Now, that brings us to the point of devastating brain injury. Now, there are several names which have been given to this type of brain injury: severe brain injury, catastrophic brain injury, devastating brain injury, non-salvageable brain injury, all of which imply a poor prognosis. However, not all mean the same thing, and very often each one who describes a particular type of brain injury means something different. And therefore, what we are first going to try and do is try and see what devastating brain injury really means. So what do we mean by a devastating brain injury? The definition as given in 2009 in this paper was a penetrating and/or blunt trauma to the brain or a devastating stroke, which has been evaluated by neurosurgery. The injuries are deemed to be non-survivable and not amenable to neurosurgical intervention, and ongoing resuscitation requirements by the critical care services are done basically to maintain organs. More later, as late as in 2015, this was the definition given, where devastating brain injury was defined where there is an immediate threat to life from neurological cause upon presentation to the hospital. So this is a very a nice, concise definition which was given in 2015, which defines exactly what it means, that there would be a threat to life from a neurological cause when the patient comes to you. Now, what happens is that very often many of these patients are deemed to be non-salvageable, and nothing further is done in these in the hospitals or in the medical institutions where these patients are seen. The question arises as to whether this is right and what needs to be done actually, and how do you decide what needs to be done for which patient. Now, it's important to understand why we are specifically looking at this condition of devastating brain injury, because it's important to identify the specific patient population and not make it a general term for any patient who has got a serious brain injury. This is important because we must avoid a pessimism and a nihilism. We need to present the right picture to the family and to provide a standard of care in such a way that it gives the best chance to the brain to survive, as well as improve the functions of other organs. Now, what is important is that we must understand that what we talk about in devastating brain injury is not the same as in serious head injuries where the patients can survive. And therefore, it's very important that we tell the family exactly what we mean. It's also important that we give the patient the standard of care which is possible in all parts of the world, and we also need to look at the functions of other organs in case the patient becomes brain dead. We need to make sure that the other organs survive. It is interesting to see that over a few decades, traumatic brain injury has actually dropped. If you look at the percentage of cases of devastating brain injury as a cause of devastating brain injury, while brain tumors and traumatic brain injuries have dropped significantly, cerebrovascular disease has increased in significance. Now, coming to the data on devastating brain injuries and their outcomes, in 1995, there was this paper on the outcome of devastating brain injuries, where of the 24 patients in whom life support was discontinued, 2 patients actually survived. And of the 23 patients whose life support was continued, only 5 patients survived. What this actually means is that whether you continue life support or you discontinue life support, where there is a serious head injury, there are patients who would survive. However, I must say that in this paper, the outcome was looked at of severely head injured patients of a Glasgow Coma scale of 7 or less, and therefore it was not really a very, very devastating head injury. This paper in 2006 looked at what happened to GCS and bilateral fixed pupils, and they asked the question, do they have any chance of survival? And they concluded that patients with a GCS of 3 and bilateral fixed dilated pupils most often died. However, there was a statement that there was a tendency in these patients for a less aggressive treatment. Now, did that play a role? We don't know. But however, if the pupils were reactive, even if the GCS was only 3, only 42% died and the majority survived. In 2009, this paper looked at the outcome of patients with blunt head trauma and a Glasgow Coma scale of 3 at presentation. 50% of these patients survived, and about 13% had a good functional outcome at 6 months, which is a very, very significant factor. And this is, I think, a very important statement which they made. And pupillary reaction, according to them, was an important prognostic factor. There was a 23% mortality with reactive pupils and an 80% mortality with non-reactive pupils. Now, just hold on for a sec and look at this statement. For non-reactive pupils, there was an 80% mortality, which meant that actually 20% of patients with GCS of 3 and non-reactive pupils actually survived. And therefore, aggressive treatment is important even if the GCS is only 3. Now, in this paper again of 2009, they looked at the survival of trauma patients with coma and bilateral fixed dilated pupils. And what they said, which is actually a very important statement, that it is very important to look at the pre-hospital GCS, because very often when patients are brought in, paramedics could be intubating patients or either at the site of the injury or on the way to the hospital. And therefore, it's important to look at the pre-hospital GCS. And what they said was, of course, that patients with a GCS of 3 and bilateral dilated fixed pupils have no chance of survival. In 2012, there was a paper in the British Journal of Surgery which looked at pupil in addition to Glasgow Coma scale, and they said that even if there was bilateral dilated pupils, a good outcome was seen in 8% of patients. Now, what does this show? A small but definite percentage of patients with a GCS of 3 to 4 and pupils bilateral dilated and fixed do survive. And if the pupils are reactive and have a GCS of 4 or more, there is a very reasonable chance of survival. We must therefore understand that we must not create a pessimistic attitude just because the patient's GCS is less than 5 or 6, nor must we be very, very pessimistic if the pupils are non-reactive. But what is, I think, very important is the CT scan finding on radiology of a brainstem infarct. These patients definitely do not survive. Now, the other prognostic factor on radiology that has been mentioned in literature is in this paper in 2012, which looks at the significance of traumatic brainstem injury on T2-weighted MRI, where the authors suggest that the T2 volumes are better to look at than the gradient echo images, and that the injury to medulla and bilateral injuries to the pons do not recover. These patients do not recover. No patient with a midline crossing lesion or a GCS less than 4 recovered when you had these traumatic patterns. And majority of patients with lesions that did not cross the midline recovered, which means that if you had a medullary injury or bilateral injuries, that is a very, very poor prognosis. The other clinical point which was brought to attention in this paper in 2011 was the response of ICP to treatment as a predictor of death. And what the authors said was that patients with a GCS of less than 9 who responded to ICP lowering treatment had a 64% lower risk of death than those who did not respond. Now, looking at all this, we need to have protocols and we need to look at which sort of patients would survive and which would not. But however, this paper in 2015 mentions that risk prediction models are often, while they have a statistical performance to support their use in research, they are not really useful when it comes down to clinical work and to guide individual patient decision making. You cannot really go by these prediction models in your everyday work.
Okay, excuse me, Professor?
Yeah.
You're on the third slide. Is that the one you want to be on?
No, I'm far beyond the third slide.
Okay, click on the slide you want to be on. That's good. That's good. Oh, thank you.
Yeah. Are you seeing the slide now?
Yes, I am. We are. Yeah.
Okay. Oh, you were not seeing the slides before. Okay.
No, we see them now. We see them now.
Okay. So what I was saying is that these risk prediction models are useful in research, but not really in individual patient decision making. And therefore, while scoring systems are proved useful for gauging the immediate impact of disease, they all share caveats of imprecision that limit their use and accuracy in prognostication, clinical decision making. And I think that's something which across the board most people agree on. So how do we really define devastating brain injuries? So what we do is we define this when a patient has a GCS of 3 to 4, when the pupils are dilated and not reacting, when there is a CT scan evidence of a brainstem infarct or an MRI evidence of medullary injury or a bilateral pontine injuries. Now this actually forms the definition of a pure devastating head injury. All other combinations would not be a devastating head injury, but you can call them catastrophic injuries or serious injuries. Now, what the Neurocritical Care Foundation have recommended in this paper in 2015 is that don't make an observation or decision based on a single clinical finding. You need to observe the patient, and therefore you need to do repeated examinations over a period of time to establish greater accuracy, and they recommend a 72-hour observation period before you decide on taking a further step. Also recommended in this journal from Critical Care that it is very important to have a protocol in each institution to look after these patients and manage these patients. You can't make everyday case-to-case decision just out of the box. You need to have a protocol whereby all members of the team are guided by that protocol, and therefore, and this is associated with an improved survival in serious patients. And therefore, we have suggesting a certain protocol. This is what we use at our institution. What we have is first the determination of the severity of injury, which is done by 3 clinical points and 1 radiology point. The clinical points are that of the Glasgow Coma score, the pupillary size and reaction to light, and the brainstem reflexes. And we also look at, after that, the radiology, which is the CT scan finding. When you take these 4 points and put them together, you come across 4 scenarios of devastating injuries. So if you look at the devastating injury scenario 1, it comes with pupils dilated, not reacting. You have the brainstem reflexes absent with radiology showing a brainstem infarct. Now, the recommended action for this is that if it is the same after 48 hours, then you need to plan for maintenance of organ perfusion and declaration of brain death. Scenario 2 is when the pupils are dilated and not reacting, the brainstem reflexes are absent, but there is no brainstem infarct on radiology. Then the recommended action is aggressive treatment for at least 48 hours. It may be surgery, it may be just medical treatment, but for 48 hours you give aggressive treatment, relook at the patient, and then decide on further management. Scenario 3 is when the pupils are reacting, brainstem reflexes are present, but radiology shows a brainstem infarct. Once again, aggressive medical and surgical treatment for 48 hours at least, relook at the patient, and then take a decision. Scenario 4 is, of course, when the pupils are reacting, brainstem reflexes are present, there is no brainstem infarct, you need to continue aggressive medical and surgical management, and these are patients who would definitely show some improvement in survival. And therefore, we come to a definition which is guided by the GCS, the pupils, the brainstem reflexes, the radiology, which is of CT mainly. MRI is used only when we are not sure, after a period of time, after 48 hours or so, when you really want to know and prognosticate to help the family decide on further management. Otherwise, I don't think MRI is of use in the initial management of these patients. Aggressive management and maintenance of perfusion of organs is very, very important in these patients. Nihilism must be avoided, and we must look at how to manage these patients, because a significant number could be saved, and otherwise we could maintain the organs for organ donation. So in conclusion, we need to avoid nihilism regarding so-called devastating head injuries, because a good percentage do survive. Maximal critical care, aggressive management is required by both the critical care and the surgical team for at least 48 hours, where you need to relook at the patient. I don't think we should take decisions the minute the patient comes into the ER and is shifted under neurosurgery or under neuro ICU care. And even if the patient is beyond survival, I think maintenance of organs is very important. I think this is my last slide. Thank you very much for listening.
Okay, Professor, thank you very much for an excellent talk. Well presented, very clear slides. And coincidentally, we have a couple of patients that are going to be speaking in a couple of hours, matter of fact, in about 4 or 5 hours. and they're going to kind of give their side of the story about what it's like to have a traumatic brain injury and what it's like to recover, etc. Okay, Ramesh, do you have comments or questions for your buddy?
Sridhar, that was a great talk, and the way you analyze all these papers, I think that gives a perspective about what is important in cases like this. And the institution I work, which is the Imperial Trust, and the major trauma center we have participates in the head injury trials in combination with Cambridge, and some of the papers you have presented is from Hutchinson, who we know very well.
Yeah. The problem, my interest in this came about because we found that very often even patients who are serious and not really devastating in inverted commas are often given very negative prognostications. And that's the sad part. And I think this is what we need to send out to the neurosurgical population.
Yeah, I completely agree. And one other point which which I think needs to be emphasized is a protocol-driven management, which definitely changes the outcome.
Very true. Very true. Very true.
Yeah.
I think what is also very important is that you need to be in complete sync with not only the ER, but also with your critical care colleagues. That's very important. If that doesn't happen, then very often, each one has their own philosophy, and so it has to be these three, I think, compartments who manage traumatic brain injury have to be in complete sync and work together.
Absolutely. Yeah, totally agree.
Excuse me, Ike, do you have any comments or questions for Professor? You're muted, Ike. You're muted, Ike. Ike, you're muted.
Can you unmute it?
Unmute yourself. There you go.
Yeah, hi, Sridhar. How are you doing? I was listening to your talk. Very interesting. I agree with you completely. A few things I wanted to ask you. What's the scenario of head injuries in Chennai at the moment?
Chennai has got a very bad reputation as far as head injuries go, because India tops the list of head injuries following road traffic accidents, as you know, in the world. And I think our state is number 2 in the number of head injuries. So that way the scenario is very bad. And I think in the program I saw a talk on prevention. So I think that's a very important thing, and that's what we're talking about all the time. As far as management is concerned, unfortunately, I think what is missing is the protocol-driven management of head injuries. It is often depends on the individual neurosurgeon's thinking or what he or she thinks at that point of time, or what the ER physician thinks at that point of time. It's across the board, both in private and in government institutions and academic institutions, because for many reasons. It's for space, for finance, for manpower. There are many reasons for this. But I think we need to slowly change the thought process more than trying to make everything right. I think we need to start looking at changing thought process towards making people look at unified protocols across the board, and that would then bring everybody back on the same page, and then maybe things would become better.
I've been to Chennai for a couple of times, and I was I know decompressive hemicraniectomy is a protocol, but then I saw a few decompressive hemicraniectomies for subdurals, which I mean, I wouldn't say not warranted, because it is a procedure in place right now. But I was wondering if you have had any experience with opening systems in decompressive.
Yes, after I met you in Delhi, we have actually started doing a trial uh, uh, of look. We are doing the decompressive craniectomy because that's what we do, and in addition, we are doing a cystonostomy. Uh, so what we are trying to do, we are looking at about 30 to 40 cases before we analyze our results. We are trying to look at what the outcomes are with the cystonostomy as opposed to the cases which we have done before without the cystonostomy. So this is what we are looking at presently, and let's see. I'll
Yes.
come back to you with the results.
Yes, yes, I'd be very interested. I'd be really, really interested to know about these. This would classify. I mean, are you opening the membrane of request as well?
Yes, yes, yes.
All right, right. So this would be
So
proper
what
system.
happens is that the decompressive craniectomy is done, the acute subdural is evacuated, and then we go down to the base, open the optic cistern, the carotid cistern, and then go down in the optico-carotid space, and then go down to the membrane of Lilliquist.
Fantastic. So you have found the brain to be lax after this?
We have found the brain lax, but
Yeah.
I'm more looking at results in GOS after doing this and
Yeah.
looking at an overall picture as to what were the problems because everything is noted down. So let's see, let's finish our 40 cases and then come back and see what the results are. We've had some problems. We've had some problems where we've not been able to actually get down to the base. Sometimes, in a couple of cases, I think they called me in, and it's been a little bit of a struggle to get down to the base. Maybe because we didn't drill right down. The person who did the craniectomy didn't drill right down. We're looking at all the aspects of this, and we want to analyze our figures first before I really make a statement on this.
I understand. I completely understand. Yes, I agree with you that sometimes it's almost crazy to, in a very tight brain, to go into the base. But I mean, I would like to show you probably a video as to, you know, as to sometimes how bad it can be.
Yeah.
Do you have the video now? You want to show it now, Ike?
Yeah, John. I would just.
Oh, okay.
Can I screen share?
Yeah. Sometimes it's successful with video, sometimes not. Sometimes I have to embed it on a web page. But if you send me the address to it, I can post it up.
Can you see,
Oh, there you
can
go.
you see?
Yeah, we can see that.
All
Yeah.
right.
Yeah, they're very good.
That's an acute subdural which we evacuated. I mean, you can see when the dural opening is there. Can you see how?
Yeah.
Sridhar, can you see how bad the dural opening is?
No. Yeah. Now I can see that. Yeah.
Yes. Now we are evacuating. That's a 2.5 centimeter incision, and we are evacuating the subdural. And I've gone down to the opticocarotid cistern, and then I just wanted to show that we are opening the dura after that, and then I complete the cystonostomy, and then the brain is very, very lax after that.
Yeah,
I mean, even now the brain is a bit full, but once I complete the cystonostomy and put in the drain, the brain will become very lax right now.
Yeah. Yeah, we most often we are successful. I think it's only in a couple of cases where it's been terrible.
I'm showing you a terrible case after. See how lax the brain is now. See how lax.
Yeah.
Very lax. I'm going to show you another terrible case. Immediately after this, I'm just see that is a burst slope with very high ICP. Then here no cisterns were seen, nothing was seen. So we went to the base. You see the brain coming out there. I'll show you. You see that?
Yeah.
That's as terrible as it is. But you can see once I go into the base, you can see the damage of this damage which is there. And but once I go into the base, you can see the CSF welling up.
Yeah.
I mean, this keeps on welling up. So this is we have just published the CSF shift edema, which is a different type of edema, which we say that it's only seen in trauma and subarachnoid hemorrhage, and so it's completely different from hydrostatic and vasogenic.
Correct.
And you see at the end of the closure, you see how lax the brain is.
I
It's
think I think the key to this is taking your craniotomy right down to the base and drilling it so that you can get right down.
Absolutely.
Even if you have a ledge of brain, that's going to be very tough.
Yes, absolutely, absolutely.
Yeah.
Thank you.
Well, very good. We have to move on to our next talk. So I appreciate Professor spending the time to talk to us, and thank you to the guests for coming.
Thank you.
And we'll see you at the next conference.
See you.
Sure.
Bye-bye.
See you. Bye-bye.
Okay.
Bye-bye.
Okay. The tape stops there. I'm gonna get Ann in Venice to see if we can get her on here. We have some questions about whether or not the signal is strong enough to come on with a Wi-Fi in Venice. She's there with Deepak, and all you guys probably know him, right? Deepak Gupta. Yeah, hopefully he can come in now. Ramesh, it looks like you have a good connection.
I have a good connection. Yeah, it's a fast internet. So.
You have a broadband, right?
Yes, yeah.
Okay.
Hi, John.
Oh, Deepak.
Can you see me and hear me well?
Yeah, how you doing? We did it. We did it.
Yeah.
Yeah, looks fine.
Okay.
Looks great. Great. Okay. Now let me get your screen share to make sure. We got a couple of minutes here.
No problem.
Let me get it.
Should I go ahead with the presentation from my side, or will you be doing it for me? I can do it from my side also.
Let me make sure I got your PowerPoint here. Hypothermia, right?
Perfect.
Yeah, I got your PowerPoint. I got Ann's also when she comes on.
Okay.
So do you enjoy Venice? Are you there for a conference, Deepak?
Yeah, I'm here for a lot of scientific deliberations in different parts of Italy, and so I'm in the last phase. And tomorrow I'm flying back to India.
Oh, okay. Okay. We have Ramesh here. I don't know if you know Ramesh Nair.
Hi there.
Have you met him before?
Hello, hi Deepak.
Not really. It's a pleasure meeting you for the first time at this platform.
Absolutely,
Okay.
it's been fantastic. To meet
Okay.
people.
And yeah, it's really going well, Deepak, and we appreciate you making the effort to do this. So okay, let me just. This is all going to be edited out. I'll start and give you a formal introduction, and then I'll introduce Ramesh and introduce you, and then you're off to the races.
Okay.
And when we do the PowerPoint, just say next slide, please. That's all. Okay.
Okay.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is good morning, actually. This is Dr. John Bennett, broadcasting from Miami. This is in a continuing series of the online conference for the ACNS, the Asian Congress of Neurological Surgeons, headed by Ip Cherian. Today we have the honor of having Deepak Gupta, MD, a neurosurgeon from India, who's made the special effort while in Venice to communicate with us, and we really appreciate that. Let me first introduce the guest. We have Ramesh Nair, and have him say hello. Hello, Ramesh.
Hello, hi Deepak. It's nice to meet you here. I'm a skull-based and neurovascular surgeon in London, working at the Imperial Healthcare Trust, which is part of the Imperial University. I work at Charing Cross Hospital, which is one of the main hospitals in London. I've been here for more than 10 years now.
Nice to meet you here.
Very good. Okay, Deepak, it's all yours.
All right, thank you very much. And first of all, let me congratulate Ip Cherian and let me thank the entire team of ACNS for giving us this platform. It's a very unique opportunity and unique means to interact with the people who are not actually sitting in front of you, but it's almost like a virtual world, I would say. So thank you very much for the opportunity.
You're welcome.
So should I go ahead with my presentation?
Okay, sure. Okay, let me make sure. Let me share it here to make sure you see it. Okay.
Can you just make it bigger?
Okay. Can you see it? Okay.
I see it well, but the slides are very small. But if you make it bigger,
okay, hold on. Let me see if I can.
Yeah, that's fine.
Okay.
Yeah. Should I go ahead?
Yes, please.
Well, okay. So in the next few minutes, I'll be talking about my experience with hypothermia in severe traumatic brain injury or the head injuries. I'm presently working as additional professor of neurosurgery at All India Institute of Medical Sciences, New Delhi, and is associated Jayaprakash Narayan Trauma Center. I also hold the status of principal investigator from India for the recently concluded Eurotherm 3235 trial, with the results of which have already been published in New England Journal of Medicine. I don't have any disclosures. The next slide, please. Well, hypothermia, I would say, is as controversial as most exciting things in life are. For the beginners who do not know much about hypothermia, well, it basically consists of lowering of the deliberate of the body temperature. It can be used either as a prophylactic means, wherein we call it as a protection use of hypothermia, or it can also be used as a therapeutic modality for control of brain intracranial pressure. By default, conventionally, we are using a temperature of 32 to 35 degrees Celsius, which is actually a mild hypothermia, I would say. 32 is in the moderate hypothermia range. And the initiation, duration, speed, and means of cooling actually varies in different cities and by different centers. Next. Well, some time back, somebody said this thing for me. One of the ex-president of Neurotrauma Society of India said this for me. You can love him or hate him, but you cannot ignore him. And I think I feel the same about hypothermia. Hypothermia is in clinical practice for last, I would say, many decades. In fact, many centuries. If you go back to the history of papyrus and his methods, However, it is something which is very, very controversial. I mean, there have been hundreds of papers talking in favor for it and hundreds of papers talking against it. Let's see where I take you in my present journey in the next few minutes. Next. All right, this is purely historical interest, and as you can see, if you go back to the history of 450 BC, people have been using using the snows to improve the survival for packing the wounds, and it has been used in the battlefield by various surgeons at that time. Next. Next slide. Well, the mechanism of action of hypothermia is pretty simple and straightforward. It basically acts as a cerebral protection, and we all know that the as and when the more and more of neuroprotection action of hypothermia we get, at the same time, the incidence of adverse side effects also increases in hypothermia. That is something which we need to be very, very careful about. And this is how it commonly acts. It acts by retarding the destructive intracellular enzymatic reactions. It acts by reduction of calcium in blood, by decreasing the free radical generation, and, and so many other things. In the interest of time, I will not be talking much in detail about the various mechanisms. Next. Well, this slide is something which is very, very commonly used, and most of the neurosurgical residents all over the world, they know about Brain Trauma Foundation guidelines. And many of them actually do not read about Cochrane data review or the publications in the Lancet Neurology coming in different time frames. But what a neurosurgical resident or a neurotrauma intensivist commonly knows is about the BTF guidelines. And this is a message actually carried forward whether one particular modality of treatment is useful or not. So if you go back to the BTF guideline of the revised ones which came up in 2007, it says that there is a level 3 evidence, and yes, preliminary findings do indicate that there is a greater decrease in mortality risk when targeted temperature is maintained for more than 48 hours. However, the difference was not statistically significant. So there is a chance of improvement of using hypothermia, and you can see on this forest plot, the red line, if you see, it is favoring hypothermia. Next. Now, why we are using hypothermia? Well, the major people who have got the maximum benefit in hypothermia are the cardiologists, I would say. There have been enough publications coming up on the efficacy and usefulness of hypothermia in out of hospital cardiac arrest, and the literature is replete with many such publications. So hypothermia can have very significant effect on various patient populations, acting as a powerful societal protector. Next. And in the kids, it has been seen that the children with the neonatal ischemic encephalopathy, the hypothermia has been shown to have significant benefit based on the Cochrane systemic reviews. Next. We must understand that the problem is all the hypothermic trials which are actually available. If you go back and read the animal experiments, most of the animal experiments so far have shown very, very useful benefit of hypothermia. However, somehow we have not been able to translate it to the clinical practice. So now it is basically time for us to take the bench to bedside and back to the bench in order to move the field forward. That is something we really have to understand in case we want to take the hypothermia further. Next. Now, these are I mean, this is a very busy slide, but you can see the mechanism by which hypothermia actually acts. It basically acts at different phases, the acute phase, subacute phase, and the chronic phase. It basically, the most important role, if I am to summarize this busy slide, I would say, it decreases or mitigates the effect of reperfusion injury. That is something which we need to be very, very careful about. Next.
Okay, I'm sorry, ischemia and trauma. Okay.
Yeah. Okay. So for those who have not been giving hypothermia on a regular basis, and for the young audience in this gathering, hypothermia basically can be induced either by the peripheral cooling or by the core cooling. The peripheral cooling is usually by using air or the circulating blankets. In fact, most of the trials which have been published in the literature, and including the European trial, we use the air surface cooling blankets for cooling our patients. People have also used ice packs, cool caps, helmets, specially designed beds and water alcohol streams and sponge baths for cooling the patients. Very recently, especially in the ongoing HOPE trial, people are using the intravascular catheters. I'll come to that how it is done. And for the core cooling, we have to use conventionally ice cold saline at a temperature of 4 degrees Celsius at a rate of 25 to 30 ml per kg of polymer. Then we also have to resort to some antipyretic drugs, esophageal cooling device, and in fact, direct brain cooling is also been advocated by a certain group of people for cooling the patients. Now, the issue which you need to remember is most of the hypothermia trials so far which have been, they have been based on one hypothesis. Earlier, you could the benefits. Somehow, most of the results of the NEBIS trial 1 and 2, they actually failed drastically, significantly, primarily because they were not able to cool the patients early. And that is why the presently ongoing HOPE trial, people are actually using the intravascular catheters, because when you use the intravascular catheters, you are able to achieve the target temperatures much, much earlier. I would say within a period of 2 to 3 hours, you can reach a target of 32 to 34 degrees Celsius, which is actually what we want. Next. All right, so this is how a patient actually looks like in an ICU setup. And the hypothermia, I would recommend it is to be done only in high volume centers which have got a very strong backup of a neurointensivist team with you. You need to have invasive blood pressure monitoring, central venous pressure lines, rectal and esophageal temperature probes. The ICP monitoring is a must for the patients undergoing hypothermic therapies. Patients need to have a very intensive neuronursing monitoring by the hourly urine output, blood sugar charting, LFT, KFTs, coagulation profile, lab assessments, temperature corrected ABGs, and the access to that doing the CT scans. We in Jayaprakash Narayan Apex Trauma Center are lucky enough to be blessed with state-of-the-art mobile CT scan inside the ICU itself. And in case you have got access to all these facilities, you are able to do these investigations on your own. Next. All right, so basically the technique is pretty simple and straightforward. It basically consists of cooling the patients by using the ice cold IV saline at a rate of approximately 1.5 liter of ice cold saline is given to the patient over 1 hour period, and subsequently the temperature is maintained by surface cooling blankets. All these patients naturally they have to undergo elective intubation, and they are sedated with midazolam and fentanyl. They are on full ventilatory support. The most important thing is to be remembered, everything changes completely when the patient is on hypothermia, because the metabolism of all the drugs changes completely. And so you need to have a neurointensivist who needs to adjust the ventilator settings when the patient is cool from a temperature of 37 degrees Celsius to 35 and lower down. Also, it is important to understand and know that when these patients get some infection, which does occur in some of these patients, there's an increased load on the machine, on the mechanical ventilator, and that needs to be picked up, and the ventilator setting needs to be adjusted accordingly. The monitoring, as I've already conveyed, they need to have a series of non-invasive and invasive monitoring when the patients are undergoing hypothermia therapy. The other thing which is very important is how to rewarm the patient. The rewarming rates have to be very slow, to the tune of 0.025 degrees Celsius every hour. It has been seen, if you rewarm your patients early, the incidence of side effects, complications are very high, and in fact there is episodes of rebound intracranial hypertension also are very, very high. So that needs to be taken care of. Second thing which we need to understand and know, that hypothermia is something which is not free of problems. It is something which is to be given only in advanced ICU setups, as a lot of these patients, they do have episodes of shivering, which can actually mitigate the effect of hypothermia. There is an increased incidence of pneumonia, coagulopathies in patients who are being cooled. So all those things have to be very delicately and thoroughly managed by a team of neurosurgeons and neurointensivists together. Next. So basically you need to control, these patients usually have got insulin resistance, so they have got incidence of hyperglycemia, hypokalemia when the patients are being cooled, and the reverse occurs when the patients are rewarmed. So all these things have to be really, really taken care of. Next. Now, so we in the Eurotherm trial, which was recently completed, I'll come to the Eurotherm trial in the last part of my slides. So at All India Institute of Medical Sciences, we had 34 patients out of 375. Approximately 10% of the patients of the Eurotherm trial were contributed by our center, and interestingly, our results were very satisfactory. In fact, the hypothermic patients, none of these patients had got any episode of coagulopathies or pneumonia in our series, and the chances of conversion of DC was also not significantly higher in the patients undergoing hypothermic therapy. Next. And we had an excellent graded response of fall in the ICP noted with the hypothermia. In fact, this is what is there in the literature also. Hypothermia per se, I mean, there is no doubt that the graded control or the reduction of the intracranial pressure is beautifully managed with the hypothermia. There is no doubt about that. However, controversy shrouds whether the usefulness of hypothermia in its value as a neuroprotectant. Next. In fact, if you see the ICU stay of these patients when they were receiving hypothermia was lessened. The total hospital stay was lessened. The number of episodes of ICP intracranial hypertension were lessened in the hypothermic group as compared to the normothermic group. Next. And so in fact, this paper was one of the top 5 award paper in the International Neurotrauma Congress in the Budapest in 2014. And the average time to attain hypothermia in our series was 2.6 hours. Next. Now, we must understand most of the hypothermia trials they are jinxed with early stoppage for futility. Because if you talk about the Cool Kids trial for the children, if you talk about National Acute Brain Injury Study 1 and then 2, if you talk about in fact the Eurotherm trial also, all these trials have been stopped early for lack of futility. So is there any hope for future? Next. If you talk about the Cool Kids study, this was carried out by David Edelson by the Phoenix group. It was again terminated because there was no significant difference between the hypothermic and the normothermic group found at 3 months after the injury. There were 35 cases, 350 cases were randomized for this study from 12 centers. However, only I would say 77 patients could be enrolled in the study, and when the futility analysis was done, the results were not found to be satisfactory, and so this trial was actually stopped prematurely. Next. So this shows what are the biochemical and metabolic changes taking place in the patients when they are undergoing or when they are being cooled. People have got very high incidence of hyperglycemia and insulin resistance, metabolic acidosis, shiverings, and disturbances of electrolyte balance during the cooling phase, and subsequently the reverse occurring in the rewarming phase. Next. Now, what are the red herrings for hypothermia? Most of the hypothermia trials, I would say, is primarily because they have failed. The people have been giving insufficient regard for the side effects. It basically causes the partial negation of protective benefit of the hypothermia. So, in case you are not able to manage the side effect of hypothermia, which is actually one of the manifestations of hypothermia, I would say, naturally you will have more complications, and this has actually led to the poorer outcome in the patients of hypothermia in the trials which have been concluded. So in case you are able to really manage those side effects well and by a careful planning and a good neurointensive control, I'm sure the outcome of the hypothermic patients can be improvised. Next. This is the first trial on hypothermia, I would say, was published in New England Journal of Medicine. The Clifton, in fact, has done the National Acute Brain Injury Study Part 1 and Part 2 was subsequently done in 2007. And again, the first trial was stopped for lack of futility and showed no improvement with the hypothermia. However, from the results, they did conclude that probably very early cooling may improve the neuroprotectant value of hypothermia. Unfortunately, there were more events of critical hypertension in hypothermic group. Next. Now, the game changers in hypothermia, I would say, are the Chinese group. Professor Jiao Jiang. I mean, they have a very different policy as compared to the rest of the world. Professor Jiang, actually, they feel, and in fact, they have been giving hypothermia routinely to their patients. They found that patients who have been cooled very early and very prolonged for more than 5 days, the outcome of the long-term cooling is more efficacious as compared to the 2 days of short-term cooling. And you can see the favorable outcome in the patients who were cooled for the longer period were significantly higher as compared to the patients who were cooled for a lesser duration of time. So the Chinese group of people are very much strongly propagating that you have to cool the patients for a longer duration of time. And actually this is scientifically also explainable, because we must understand in the initial days, in the very early phase, the neuroprotectant value of the hypothermia actually depends on how early you cool the patient, because the neuronal cell death starts taking place very early after head injury. However, we have seen that patients have got rebound intracranial hypertension taking place after 48 hours, 72 hours. And it is during this phase, if you are cooling your patients even after 2 days or 3 days, you can control those episodes of intracranial hypertension. So begin early and continue long. That is the message from this group of people. Next. So this is a post-hoc analysis which Clifton carried out in 2011 after the 2 trials, and Andrew Moss very nicely concluded, we do not think that the present study puts an end to hypothermia and traumatic brain injury. Rather, it should stimulate further studies in which depth and duration of hypothermia as a therapeutic strategy should be better targeted to the individual needs of every patient. And I think what Andrew Moss says is pretty correct. Next. So in fact, when the post-hoc analysis of NABIS 1 and NABIS 2 was carried out, it was concluded that you have to identify certain subsets of patients. I would say the patients of acute subdural hematoma, which have got very high incidence of reperfusion injuries. These are the group of patients who should be targeted. You should be cooling these patients very early. These are in fact the messages which came up from when the NABIS 1 and NABIS 2 trials were critically analyzed, and that is what that has paved the way for HOPS trial, which is actually presently going on in Pittsburgh. Next. And Walter Dietrich has from the Miami has got immense experience on the hypothermia, especially the animal experiments, and somehow he also feels that now it is time to go back to the benchside research, because somehow we failed in the bedside when we tried to translate the results of animal experiments to the human studies, but now it is time to go back to the benchside to see where actually we went wrong to further improve the outcome in the hypothermic patients. Next. And in fact, if you look at the Cochrane data review also, Cochrane data review carried out in 2009, it does recommend hypothermia to be used in the context of high quality randomized controlled trial with good allocation treatment. That is something which is very, very important. It is not, I don't advocate, I don't canvas, and I don't advise that hypothermia to be used at each and every center. Only in the centers who have been doing hypothermia on a regular basis, who have got good backup, good support, good intensive care, only those centers it should be done, and there too as a part of high quality randomized controlled trial as of today. Next. And this is a few meta-analyses which have been published. I'll skip that in the interest of time. Next. And subsequently, can we come to the next slide? This is another interesting paper. In fact, I would say this goes more in benefit of the Asian population. It was published in Brain Injury. And when further subset analysis or of meta-analysis was carried out, it was found that moderate hypothermia may be effective in reducing death and unfavorable clinical neurological outcomes. And this finding is not statistically significant except for decreasing the mortality in Asian patients. So this actually people have gone to the extent of analyzing and reanalyzing in depth where they went wrong, and when subsequent analysis have been done, it has been noted that in Asian group of patients the mortality rate is lower with the when in the moderate hypothermia group. And why it is so? Next. People in various institutes have actually, this is an unpublished work from one of my friend in Copenhagen, and she has actually carried out the genetic level of work in these patients who have been cooled with the hypothermia, and there have been some genetic abnormalities and upregulation of the genes taking place in when the patients are cooled. So there are some genetic changes taking place in different subsets, accounting for different outcome of the hypothermia in different population group, I would say. Next. Now it is basically time to relook into the hypothermia targets. We have to understand that the Glasgow Coma Scale has got nothing to do with the disease itself. I'm sure. I mean, the patient of contusion, the patient of subdural hematoma, diffuse axonal injury, extradural hematoma, they're completely different altogether. And we should not be basing our treatment purely on the GCS. It has got nothing to do with the pathophysiology of the disease. Come on. So, if you really see, the incidence of ischemic reperfusion injuries are the highest in patients of acute subdural hematomas, and these are the patients I personally feel they should be the potential targets in the future hypothermic trials. Next. In fact, it has also been seen that hypothermia, apart from having an influence on ischemic reperfusion injury mitigation, it also helps in decreasing the CSD, or the cortical spreading depolation. Probably there is a class 5 evidence, I would say, that therapeutic hypothermia reduces post-traumatic epilepsy. Next. Now, as of today, there are two trials going on in the international literature. One is by the Jamie Cooper from the Australia. They are doing a prophylactic hypothermia therapy, in which actually All Institute of Medical Sciences is a part of. Therein, they are cooling patients within 3 hours of injury, and that is the basic challenge. And the philosophy is again very clear. Begin at the earliest, because from the previous trials we have learned, unless and until we cool our patients at an ultra early period after the injury. In fact, the patients in the pre-hospital transport period, they have been cooled with this therapy. And so far, this trial is quite lucky, because it has not, the 50% data has already been carried out, and the trial has not been stopped for futility. Most of the previous trials, including the recently concluded Eurotham 30 to 35, has been stopped prematurely for lack of futility. However, the polar randomized control trial has finished its 50% landmark and is still going on. The beauty of this trial is that it does use something called as a deferred consent, because when the patients are sustaining injury early, we do not have any means to obtain consent. So because our intention is to treat the patient with a positive benefit, so we can cool the patient with the ice cold IV saline, waiting for the consent to be taken from the next of the kin of the patients. Let's see what are the results come out to be, because the results are not yet available, though the trial looks pretty promising as of today. Next. This is how the recruitment status as of now. Next. The next trial which is going on is the effect of early cooling in acute subdural hematoma, or the HOPES trial by David Okonkwo from the Pittsburgh group, and they are using a patient to cool patients with a Glasgow Coma scale of 5, patients to be cool within 6 hours of injury, and the cooling has to be minimum to be maintained for more than 3 days. That is a basic thing in this trial, and the patients are cooled by the intravascular catheters. The idea is again very clear, that we want to cool the patient at the earliest possible. However, yes, there are some apprehensions and kind of raised eyebrows raised by the people, because uses of intravascular catheters to cool the patient, apart from it being very expensive, is not free of side effect and the complications. So that is something which is to be seen when other centers start to resort to it. Let's see what are the results of acute subdural hematoma trial come out to be. Next. Well, why we are talking about hypothermia in such a great depth, we have to understand that all over the world, let it be Australia, Europe, USA, and in the low middle income countries, India, Brazil, and other parts of the world, trauma remains a global epidemic. Back home in my nation, India, approximately 1 million people die of traumatic brain injury annually. In the world, approximately 10 million people die. And on a very serious note, we have to understand that the outcome and the surgical options management in the acute TBI, they're quite negligible, and not much has actually happened at the surgical front. The search on advanced multimodality monitoring and medical means to treatment is actually ongoing, and we really have to look for some means to improve the outcome. And I personally feel, despite the failures with many trials, hypothermia is one such means which does hold some promise to have give some benefit to our patients of traumatic brain injury. Next. So the facts about hypothermia which all we should know is that it is the first treatment with a proven efficacy for ischemic reperfusion injury, and it activates a protective mechanism, or the progene activation. We have to understand that hypothermia does not cause hypertension if cold diuresis is managed. All these patients, because of vasopressin insensitivity resistance post cooling, there is an episode of cold diuresis which leads to loss of water from the body, which leads to hypertension. So in case you adequately and clearly manage your fluids by having a anticipation that this is what is going to happen to the patient, the episode of hypertension does not occur in hypothermia. It actually does not cause hypothermia, though people talk about the arrhythmias happening. It does not cause arrhythmia. In fact, I would say the mild and the moderate hypothermia actually treats arrhythmias. It is mild and the moderate hypothermia is safer than the deep, so we should be aiming for a temperature of 32 to 34 degrees Celsius. We have to understand the ventilator settings. Have to be very critically adjusted when the patients are being cooled. There have been episodes of increase in the infection rate and the pneumonia in patients of hypothermia, so they need to be managed accordingly by using selective digestive tract contamination, erythromycin, daily cultures and antibiotic therapies in a very planned way when you are cooling these patients. Next. So you can see these are a couple of patients when the CT at admission and after 5 days when the patients have been managed by the hypothermic therapy, the cisterns have opened up and this patient actually went on to make a good recovery. Next. Well, as I said at the beginning itself, you need to have an advanced ICU setup while monitoring these patients and cooling these patients. Next. Yes, this is how the hypothermic machine, the Arctic or the GMR machine for the surface cooling actually looks like. These are various intravascular catheters which are used for cooling the patients. Next. Now, who should use hypothermia? Whether it should be used routinely or not? Well, we do have certain preliminary guidelines by Neurotrauma Society of India or the Indian Head Injury Guidelines, which actually mention that hypothermia is actually experimental and should not be instituted in the patients. However, I do have a different opinion, and I feel that hypothermia as of today should be used as a part of high quality randomized control trials in high volume centers with having a reasonably decent experience with the management of these patients. Next. And so, these are the results of NEJM published Eurotham 3235 trial. In fact, this trial has also been stopped, and in fact, we were actually looking. This trial will be a game changer and will tell us whether the hypothermia is to be used or hypothermia is not to be used. But needless to say, every trial or every study which has been carried out so far, they do have some flaws or some shortcomings in them, and Eurotham trial was not an exception to it. In fact, the incidence of unfavorable outcome was slightly more in the patients of hypothermia group as compared to the patients in the control group, thereby putting a stop. Thereby, the conclusion from this study was therapeutic hypothermia plus standard care to reduce intracranial pressure did not result in outcomes better than those with standard care alone. Next. These are the group of patients. The most interesting thing about this Eurotham, we have to understand that they were cooling their patients as longer as after 12 hours of injury. In fact, if you see this very carefully, over 176 cases were cooled more than 12 hours after the injury. Patients were included in the study up to 10 days post-trauma. Patients who had one or neither reacting pupillary response, they were more in the hypothermic group as compared to in the control group. Marshall's classification, there were more number of patients of diffuse axonal injury with a grade 1 to grade 3 in the hypothermic group as compared to the control group. And it has been shown that these are the group of patients which are unlikely to be benefited by the hypothermia. So probably there was something wrong in the group classification in this patient in the post-facto analysis. Next. However, the control of intracranial pressure and was very well managed. All these patients had a very good graded control of the intracranial pressure with the hypothermia. Next. This is the primary and the secondary outcomes in the hypothermia versus control. There was no benefit of hypothermia in the Eurotham trial as compared to the normotherapy group with standard of care. Next. So my take on hypothermia in the present context, I would say is hypothermia for severe traumatic brain injury works with correct patient selection. It is recommended only in tertiary care advanced trauma centers with high volume severe traumatic brain injury adult subjects being treated on a regular basis. It should be done as a part of high quality, well designed, super selective randomized controlled trial with controlled parameters for starting, maintaining and removing these patients. And the most important thing is that you have to know your tools. You should have a very good amount of experience with cooling of these patients to avoid and to manage complications of therapeutic hypothermia, which are actually preventable mostly. Next. Thank you very much. Thank you.
Okay, let me get my volume on here. Thank you very much, Dr. Gupta, and really thank you and Ann for making a special effort while you're in Venice under circumstances on the road, connecting on the road. Dr. Nair, are you still there? Hello, Dr. Nair? Well, yeah, I just want to make a remark. Of course, I don't have a lot of, I'm not a neurosurgeon. I just read about anecdotal stories that I'm sure you're aware of that happen. In
Michael Schumacher.
yeah, in the U.S., mostly they occur in kids, and actually they weren't part of a study. These are kids that maybe fell into the water, cold water, while ice skating, and there'll be anecdotes of them surviving. Now, I don't know if it's characteristic or it's just rare instances. Do you have any remarks on that at all? No, I don't know if India has that kind of.
Well, you're right in saying it. We must understand that traumatic brain injury is a heterogeneous population.
Mhm.
And unless and until you have got a huge data to back up, to substantiate the results, whatever the trials, the randomized control trial you will do, you will not get good results. We know about the story of Michael Schumacher, who was actually subjected to hypothermia. We know about the story of Anna Bergdalen, a Swedish radiologist who survived. She had in fact 91 skiing race wins, and she survived hypothermia when she was buried in the snow for more than I think 3 days. He was paralyzed, and she came back to the normal life way back in 1999, and now she is a practicing radiologist in Sweden.
Okay.
And we do know about episodes of patients being. In fact, this is one of the means people use when they have exhausted all their resources, thereby saying that hypothermia does have some value. I mean, it just cannot be ignored. It has to continue in the practice, but only in a very guarded way, only at the advanced centers of care. The crux of hypothermia is that you have to begin very early as 3 hours or within 6 hours of injury, and you have to continue it at least for 4 to 5 days. The reason people are actually scared of continuing hypothermia for more than 48 hours or 72 hours is that the incidence of complication and the side effects like coagulopathy, pneumonia, infections, and electrolyte disturbances, it increases after 3 days. So people are more conservative to manage that. However, if you can foresight those complications by having a good backup supported neurointensivist with you, I'm sure the outcome with the hypothermia can be at least reduced significantly. This is my personal feeling. We have been giving hypothermia as a standard of care in any trauma center. I've also completed my study on hypothermic and studied the effect of hypothermia on the metabolism of the various anti-epileptic drugs. I've also correlated hypothermia with cerebral microdialysis. They have documented that yes, the incidence of ischemic injury is less when the patients are cool by doing the lactate pyruvate ratio in my group of patients. So it cannot be completely ignored. However, I am not giving a message to the masses and the media that please cool all your patients. No, you have to cool a very selective subsets of patients. However, if you cannot cool your patients, the message I want to give to everybody is that at least maintain normal temperature. Hyperpyrexia is disastrous to the head injury patient. Either maintain a normal temperature, and if not, if you have got adequate backup and if you exhausted your tier 1 and tier 2 therapies, then of course hypothermia is there in your pocket. Why not use it?
Very good. Very good, Doc. Okay, well, I welcome you to present further studies if you have you're doing further studies in this, and any topic that you wish to talk about on the channel of Neurosurgical TV, whether it be hypothermia or traumatic brain injury or whatever. And we appreciate the extra effort that you put in to connect with us while on the road.
Thank
So,
you very much. Thank you, John, and thank you very much once again. I'm truly honored to be a part of your team. Thank you very
oh
much.
yeah, we want the wizard to be part of it too.
Thank you. Bye-bye.
Okay. Thank you.
Bye.
Bye-bye. Okay, well, okay, now Ann steps up to the plate. Hello, Ann.
Hello, hello. Good evening to everybody.
Did you just get back from a swim?
No, no, unfortunately, no. Buonasera from Italy. Buonasera from Italy to everybody. Thank you very much for this very kind invitation. It's a great honor for me to be part of your.
Oh, okay. Okay, we're not recording yet, Ann, but we'll let me just tell you how we'll. This is all going to be edited out.
Yeah.
Basically, I'll just introduce you, and you can talk a little bit about yourself, your background, and then go into your presentation. Let me make sure I got your PowerPoint all set and everything. Yeah, I bet you tell Americans that. Go swim in the water. It's beautiful. Come on, Ann, tell me that. You do that, right?
Sorry?
Okay, neurosurgical. Okay, here we go. Let me make sure I got it, Anna. Okay, I got to make it bigger too, which I didn't do for Dr. Gupta. Okay, let me show you the. Okay. Okay, let me make this bigger.
Yes, please.
Okay. Is that okay?
That's perfect.
Can you see it okay?
Yeah, it's okay. It's
Okay,
perfect.
good. Good, okay. Okay, let me just come back here. Yeah, in the future, you can actually use a smartphone to do
Okay.
what you're doing now.
Yeah.
But this is fine. It worked fine for Deepak, so we'll just
Okay.
continue on. Okay, let me just, Ramesh, are you there yet? Let me just check with Ramesh. He must have stepped out for some coffee. Okay, we may have people coming and joining, or we may just be alone.
Okay.
So, okay, let me see. Hold on, Ann. Let me just check on something here.
So you will move the slides from there? Yes.
Yeah. This is live. This is live now. It's yeah, it's on Neurosurgical TV, Advanced Neural Monitoring for TBI. And Mazzora?
No, Matteo.
Mazzeo.
Yes.
Okay. You know, Ann, we just had an intensivist that presented his platform for remote teaching from Canada. He was an intensivist. His name is Yannick Beaulieau, but he also is a programmer, computer programmer, and he made a platform, excellent platform for remote teaching for surgeons. So you're not the only intensivist.
Ah, good. I'm the second one. The third.
The second one today. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett, televising from Miami. Today we have another conference in the series for the ACNS, the Asian Congress of Neurosurgeons. The main topic is emerging topics in neurotrauma. And today we have the pleasure of having Ann Mazzeo. She's an intensivist from Italy. She's going to be talking about advanced neuromonitoring for traumatic brain injury. And we really appreciate Ann making a special effort to connect with us from Venice. So welcome, Ann. Why don't you just tell us a little bit about your background, where you trained, where you're working at now, before you go into your presentation.
Thank you very much. Good evening to everybody. Buonasera from Italy. I am an anesthesiologist and intensivist. I work at the University of Turin in Italy. Actually, I became interested in this neuroanesthesia, neurocritical care area during my activity for neurocritical ill patients. And then I had a great opportunity to attend a clinical fellowship at the University of Richmond under the mentorship of Dr. Ross Bullock. And so I had the opportunity to use several different neuromonitoring techniques during that experience. Now I am back in Italy. I work as a intensivist in ICU, and I still continue to use this monitoring that I believe they are really very important for a clinician who is dedicated to neurocritical illness. So we can start maybe.
Okay, very, very good. I'm interested to hear about neuromonitoring. Okay, here we go.
Okay, so we'll dedicate this next half an hour, 40 minutes, to advanced neuromonitoring in TBI. Next slide, please. And we know that among the several different treatment that we can offer to a patient during the acute phase after an acute brain injury, we can offer the opportunity of an advanced neuromonitoring that gave the clinician the possibility to have a early warning that of a deterioration in the clinical setting. So, why do we use advanced neuromonitoring after an acute brain injury? Because for sure we will have the possibility to have an early warning of deterioration in the cerebral activity, and we will be able to detect in time that something is going wrong for that patient before irreversible brain damage can occur. And then we have also to say that different neuromonitoring techniques during the years gave us the possibility to better study the pathophysiology of traumatic brain injury. And they gave a lot of opportunity to better understand the evolution of pathomechanism of acute brain injury over time. Next, please. Next slide, please. So, for people who study traumatic brain injury, we have to remind us that cerebral ischemia is recognized as one of the most important pathomechanisms responsible for secondary brain injury. We know that from different very old studies of the Graham group, neuropathologic studies, that ischemic brain damage has been identified in almost 90% of patients who died because of an acute brain injury. So this is very important because we know that a secondary brain injury may worsen outcome after acute brain injury. And at the moment, we also know that detection and prevention and also correction, of course, of secondary brain injury will allow for a better outcome in this patient. And next slide, please. Next slide, please.
Okay.
We know that traumatic brain injury is not a stable condition, but it's dynamic process which evolves over time. And furthermore, when we deal with acute brain injury, we know that we are dealing with an heterogeneous population. And so, as you can see in this cartoon, the pathophysiology of traumatic brain injury is very complex. And we know that part of the problem is related to excitotoxicity. Part of the problem is related to reduced cerebral blood flow. And a big problem is also related to the mitochondrial dysfunction after acute brain injury. So different mechanisms are responsible for the mechanism of traumatic brain injury. And we also should know that this process is dynamic. It can change over time. And this is the reason why we can be helped by using advanced neuromonitoring. Next, please. And as I already said, when we face acute brain injury, we face an heterogeneous population. And so we have to be able to match the treatment for that patient and that time. And we have also to be conscious that the heterogeneity is not only between patients, but also within the same patient over time. Next, please. This is an interesting survey of 30 different neuro ICU in the United Kingdom. And as you can see, we have several different neuromonitoring opportunity. And as you can see, we are using them in a different percentage all over the world. And recently, some recommendations from different society are coming out to guide the use of neuromonitoring for acute brain injury patients. Next, please. So, how can we ensure that the brain of our patient is viable after an acute brain injury? Of course, while in the ICU, an important part is hemodynamic management and monitoring. And hemodynamic monitoring will allow us, together with ICP monitoring, to continuously monitor cerebral pressure. Cerebral pressure is cerebral perfusion pressure is something that is really important in the care of patient after an acute brain injury. And on the other side, we have also to remember that other systemic complications may occur during the care of this patient population. So other kind of monitoring will help us in the care of TBI. But to go to the central topic of this discussion, we are now offered the opportunity in the neurocritical care to have several different neuromonitoring techniques which give us the possibility to study several different and interrelated aspects of brain physiology, brain oxygenation, cerebral metabolism, and so on. And so during the next minutes, I will try to give some aspects and some characteristics of this monitoring in the clinical practice. Next one, please. So let's start with cerebral macrodialysis. Cerebral macrodialysis is a neuromonitoring technique. It's an invasive, minimally invasive, local neuromonitoring techniques. As you can see in the picture, we have a very thin probe that is inserted either during craniotomy or via bedside Beaulieau hole. And this local monitoring is a monitoring of brain metabolism, which allow us to have a continuous monitoring of the changes that are going on in the brain parenchyma after an acute brain injury. So we insert this little probe into the brain parenchyma. We connected the probe with a macrodialysis perfusion pump, which is a precision pump that can allow to have a rate of 0.3 to 2 macroliters per minute, and we will then be able to collect fluid into vials, and the fluid that we will collect is a reflection of the brain interstitial fluid. And so what can we measure? We can measure anything that can cross the membrane, that could be energy-related metabolites as glucose, lactate, and pyruvate. We can measure marker of tissue damage. We can measure also cytokines. We know that inflammation is a very important pathomechanism after acute brain injury. So with the larger core membrane of 100 kilodalton, we are also able to measure cytokines. And then we can measure also neurotransmitters such as glutamate, or any drug that we can use during the treatment of these patients. So, for example, cyclosporine has been used during a trial of cyclosporine for neuroprotection. Next slide, please. So, which is the principle of cerebral macrodialysis? So we put this probe at the end of the probe. There is a very small membrane, and this membrane acts as a blood capillary. So any substance that is thin enough to cross the membrane, we can detect it. And so we can, any molecule which is at high concentration in the brain interstitial fluid can vibrate across the membrane. And we collect the vials, and we can then measure what is in that vial. Next, please. Next, please. So how you can see here, these are two examples of macrodialysis analyzers. On the left, you can see the CMA 600, and on the right, the newer CMA Istus. And we can have real time and bedside the possibility to study energy metabolism after acute brain injury. Next, please. Here is an example of a patient during my fellowship at MSTV in Richmond. As you can see, at the tip of the probe there is a golden part that you can then localize into the CT scan. Next, please. Why you should be able to localize this probe? Because it's very important, the location of the probe, because macrodialysis, as I said, is local monitoring, and of course what we can obtain depends on the place where we put the membrane. And for example, in this study, you can see how different can be the detection of the different molecules, depending on if the probe is in the penumbra zone or in the ipsilateral normal tissue or in the contralateral normal tissue. So it's important that we decide the place where to put the probe. Next, please. And another important factor to be considered is also the recovery of the membrane and of the analytes. The recovery, which is the percentage of the molecules in the dialysis as a percentage of that molecule in the brain interstitial fluid, and there are some factors which will affect the probe recovery. That is, for example, the perfusion flow rate. So the slower the perfusion flow rate, the larger will be the recovery. And all the other factors that you can see here in this slide, for example, the blood flow rate, the molecular weight cutoff of the membrane, the dialysis membrane, and so on. Thank you. Next, please. So, which is the clinical application of macrodialysis in human studies? Macrodialysis can help for the study of pathomechanism of brain injury, not only in TBI, but also in subarachnoid hemorrhage or after stroke or in some kind of epilepsy. Macrodialysis helps clinician to study cerebral energy metabolism and also to detect the effect on secretory amino acid release. But it has also especially an important role in trial design. In fact, macrodialysis has been used as a surrogate endpoint, for example, to evaluate putative therapies. And it has also been studied during clinical and experimental trials to measure the real concentration of a drug which can be administered and can be studied with the purpose of neuroprotection. Next, please. Here is an example of how important is the derangement in brain energy metabolism after acute brain injury. So on the left, we see what will happen in the normal brain. We know that glucose is metabolized into pyruvate, and then pyruvate will enter the citric acid cycle to produce then ATP. But in the event of an acute brain injury and in the event of ischemia, of course, we will have a shift from aerobic to anaerobic metabolism, and so pyruvate will not be able to enter the citric acid cycle and will be reduced to lactate. And the extracellular reflection of this intracellular event will be a decrease of glucose, an increase of lactate, a decrease of pyruvate, and an increase of lactic pyruvate ratio. So this will be able to measure in the macrodialysis, with macrodialysis monitoring. So macrodialysis monitoring will give us the opportunity to better study the arrangement, the dysfunction of brain energy metabolism after an acute brain injury. And we can study how this brain energy dysfunction will be modified over time, and if there is any effect on some treatment that we are using for the treatment of that patient. Next, please. So, as I said, an increase in lactate pyruvate ratio is recognized as the most important marker of tissue ischemia, and normal value are usually considered LP ratio less than 20, and an increase in LP ratio more than 25 indicates shifting of energy metabolism from aerobic to anaerobic glycolysis. And for the clinician, an increase in LP ratio has to be an early warning that an energy crisis is happening in the brain at that moment. We also have to remember that an increased LP ratio has been correlated to regional ischemia in PET studies, and an increased LP ratio has been associated with poor outcomes in TBI and also in SAH patients. And an LP ratio over 40 has been recognized to be associated with severe hypoxic ischemia and with permanent global brain damage. Next one, please. And another important thing to be recognized is that an increase in lactate and an increase in LP ratio may not only be due to reduced availability of substrates as after during the ischemia, but an increase in lactate may be also associated to a mitochondrial dysfunction. And this is very important to be recognized, and this has been very well demonstrated by this study by Paul Vespa, in which he was able to demonstrate that metabolic crisis can also happen without brain ischemia. And in this study, a 25% of incidence of metabolic crisis with LP ratio over 40 was demonstrated, but they also demonstrated only a 2.4% of incidence of ischemia demonstrated by a glucose less than 200 macromoles per liter. So the increase in lactate and the increase in lactate pyruvate ratio may also be due to the fact that the mitochondrial dysfunction will impede the use of oxygen by the neurons. Next one, please. And with macrodialysis, we can also measure the glutamate level. We know that glutamate is the major excitatory amino acid in the brain, and we know that excitotoxicity is recognized as a main pathomechanism of injury after acute brain injury. So we can also look at the trend of glutamate after injury with macrodialysis monitoring. Next one. And we can also measure the insulin level. We know that during ischemia, the energy failure will be responsible for an inactivation of calcium channels transporting system. We will have an overload of calcium inside the cells, and this will be responsible for an activation of phospholipase, and this will be responsible for degradation of the membrane, and so we will have an increase of glycerol that we can detect during macrodialysis monitoring. Next, please. And this is an interesting study that demonstrates that macrodialysis changes may happen even before ICP and CPP changes. So this will allow us to have some time in which we can do something that can help the brain of our patient before irreversible damage may occur. Next, please. Next, please.
Okay. Okay. Oh, now. Oh boy.
Next slide, please. Okay, yes, thank you. So as you can see, this is an example, is a graph in which you can see how the glucose of the patient that you can see in blue is very, very low after acute brain injury. And you can see high levels of lactate. And you can see also the yellow is the glutamate. You can see very high level of glutamate after an acute brain injury. And you can see how these parameters, metabolic parameters, can change over time after injury. And this is allowed by neuromonitoring by macrodialysis. Next, please. Literature gives some tentative normal values that we can use in the clinical practice to see how the different neurometabolic parameters are changing over time. Next, please. And as I said before, we can use also macrodialysis during clinical trials and to measure drug concentration in the dialysate. This can give us a feedback method to determine the concentration of that drug into the brain interstitial fluid. And as an example, as you can see in the next slide, this is a study that we performed at MCV, and this study aimed to look at the effect that the cyclosporine administered to a patient after an acute brain injury, the effect of cyclosporine on brain metabolism. And this was part of a clinical trial, and in this case, macrodialysis data helped us to evaluate the effect of that drug on brain energy metabolism. Next, please. And the recent consensus statement from the International Consensus Conference of Multimodality Monitoring in Neurocritical Care has been published in the Intensive Care Medicine. And this consensus recommend the use of monitoring cerebral macrodialysis in patients which are at risk of cerebral ischemia, hypoxia, and energy failure. And it's very important, and it is recognized also by the consensus that we should be able to locate the probe in the place where it can be more helpful for the information that can give to the clinician, can be given to the clinician. Next one, please. So from macrodialysis, let's move to electrocorticographic monitoring of spreading depression. This is another very interesting new technique that is used to study a very important pathomechanism of acute brain injury, which is spreading depolarization. Spreading depolarization is recognized as an electrochemical wave which propagates through the neural tissue after a pathologic stimulus and trigger. That may happen and may occur after acute brain injury. This trigger could be a local failure of brain energy metabolism, or an increase in calcium, or an increase in glutamate. And what is most important is that the occurrence of these spreading depolarizations may worsen outcome. And in the picture, in the upper part of the picture, you can see the placement of an electrocorticographic monitoring at the end of neurosurgical procedure for TBI. And along with this, you can see in the white arrow the microdialysis monitoring placed at the end of the surgery. So the combination of these two monitoring can give us a better opportunity to study the patient after acute brain injury. Next one, please. And this is a study that we performed at MCV in Richmond, where we demonstrated that spreading the polarization was more frequent during secondary insults, such as low blood pressure, hypotension, and fever, high temperature. So this is also a very good demonstration that secondary insults may worsen pathomechanism of brain injury and may be responsible for a worsen of outcome. Next, please. And in the similar study, we also demonstrated that glutamate is increased and LP ratio is increased with the increasing number of spreading depolarization. Next, please. So let's say something about brain oxygenation. We know that brain oxygenation is a very important parameter to be monitored after an acute brain injury. We have different systems that allow the study of cerebral oxygenation. The first two that you can see in this slide are brain tissue oxygen tension and jugular bulb oximetry. These are invasive monitoring. Then we have a third one that is a non-invasive one. It's the use of near-infrared spectroscopy, which allows us to have a transcranial cerebral oximetry that is non-invasive, but is, of course, has several limitations. Next slide, please. Brain tissue oxygen monitoring allows us to measure the level of oxygenation at tissue level in the brain. So we have to put a small probe, so it's an invasive technique, minimally invasive technique. It's a local monitoring because we only study the small area which is around the probe, but the information that we gain is a very important one because we are able to measure the tissue oxygenation after an acute brain injury, and we can see how the oxygenation may evolve over time, and we can also study the effect of different therapies and corrective measure in the case of a reduction of brain tissue oxygenation. Right now we have two systems available. The first is the Lycox, the other is the Neurotrend. They gave us the possibility to measure continuously the brain tissue oxygenation after an acute brain injury. Next, please. And as you can see here, this is a demonstration how, with the increasing of ICP, we will have a reduction of brain tissue oxygenation. We will have an increase of CO2, of the CO2 in the cerebral tissue, and we will have also a decrease of the pH of that tissue with the increasing ICP. Next, please. And a very important clinical message is that we have to recognize that we can have some important information when brain oxygenation is becoming insufficient for that patient. So compromised brain tissue oxygenation is recognized to be less than 20. And what is more important, it's not only to look at the absolute value, but also at the trend of that value. And it's important also the duration of the compromised brain oxygenation, and it is recognized to be related with worse neurological outcome after acute brain injury. Next, please. It has been demonstrated in this study comparing patients studied with ICP and CPP monitoring and patients studied with ICP CPP plus brain oxygenation. It has been demonstrated that the patient who has been studied with brain oxygenation, they had a lower mortality rate and favorable and more favorable short-term neurological outcome. And this, of course, was a very important result. And then, as you can see in the next slide, please. Of course, if we have a monitor, we need to use the information that that monitor is giving us. So this study demonstrated that there are some therapies, treatments that we can use to correct a low brain tissue oxygenation. And of course, the different treatment depends on the different causes that are underlying that brain tissue oxygenation reduction. For example, it has been demonstrated that if the brain tissue oxygenation was less than 25 milliliters of mercury and ICP was more than 20, then we had to use measures to reduce ICP. Or if the reason for a reduction in brain tissue oxygenation was a pulmonary problem, then we had to solve that pulmonary dysfunction. For example, by an increase in FiO2 or an increase in TIP, or if the patient is not adequately sedated, then we have to increase analgesia and sedation for that patient. So we have to treat that patient accordingly to the mechanism of the injury at that moment. Next, please. Beside brain tissue oxygenation, we also have another oxygen monitoring, which is jugular venous oxygen saturation. This is global monitoring, which gives us an estimate of the balance of global oxygen delivery and cerebral metabolism. The normal value is around 60, 75. We need to put a small catheter into the jugular vein, and it will be then moved cephalad, and it has to arrive at the level of C1, C2 to give us the better monitoring. And studying jugular venous oxygen saturation, we will be able, on the one side, to study oxygen delivery, and on the other, oxygen consumption. As you can see in this slide, in the case of a reduction of jugular venous oxygen saturation, we have to think either to a decreased oxygen delivery or to an increased oxygen consumption. So the cause of a reduction of the venous oxygen saturation could be, for example, increased ICP or an excessive hypocapnia, but could also be pain or hyperthermia or an increase in metabolism. If we have a high value of oxygen saturation, we may think about increased oxygen delivery, for example, in the case of hypercapnia, or if we have an increased cerebral perfusion pressure. But on the other side, the increased value could be related to a decreased oxygen consumption, for example, during hypothermia or during deep sedation. Next, please. It has been demonstrated that this monitoring can be related to neurological outcome, and it has been demonstrated a strong association between jugular desaturation and outcome, and also the duration of the time that SjO2 was below 50 was significantly related to a worse outcome. Next, please. Just a few words to say that we also have some non-invasive monitoring to study transcranial cerebral oximetry. This non-invasive technique is based on the principle of transmission and absorption of near-infrared light. And the importance of this monitoring is that it allows us not only to study a trend over time, but to see at the difference on both sides. We put two electrodes in the frontal region, and we can have a measurement, continuous measurement of regional cerebral oxygenation at frontal level in non-invasive. Next one. And the recent consensus conference recommend the monitoring of brain tissue oxygenation in patients with the risk, which are at risk of cerebral ischemia or hypoxia. So monitoring tissue oxygenation, cerebral tissue oxygenation, is recognized as an important monitoring which can affect neurological outcome during the acute care of these patients. Next, please.
Okay.
And we are just going very quickly to the end. We need to remember that another monitoring parameter that is important in the care of this patient is cerebral blood flow monitoring. As you can see in the next slide, we can have the possibility sorry, next slide, please. We have the possibility to insert a thin probe that is a thermal diffusion probe that gives us a quantification of tissue perfusion in that area. So this could be another parameter that we can measure in the care, during the acute care of a TBI patient. Of course, the different parameters will give us different aspects of the pathophysiology of that patient, and what is important is to select which patient may benefit of which monitoring. Next, please. This is another way we can measure cerebral blood flow with xenon CT scan. Next, please. Just a few words. We have also the possibility to use transcranial Doppler during the care of a TBI patient. It allows us at the bedside and with low cost to measure, for example, cerebral autoregulation after an acute brain injury. Next, please.
Okay, hold on. I'm a little lost here. Give me a second.
Yes.
Okay. Okay. Is that okay? Okay.
Yeah, okay. And as you can see here, when we care for the traumatic brain injury patient, especially not in the very early phase, but after the first week, we can also rely in some information given from somatosensory evocad potential, so we can have some help also from neurophysiological monitoring, which, for example, can help us in the patient who is under sedation or in the patient which have some metabolic derangement that can confuse the neurological evaluation. And of course, we all know that a lot of information can be obtained also with the use of continuous EEG monitoring in selected population. For example, for patient in which we suspect subclinical seizures. Next, please. Here is the recommendation for electrophysiological monitoring from the same consensus. They recommend EEG in all patients with acute brain injury and unexplained and persistent altered consciousness, or, for example, in patients with continuous status epilepticus, which do not return to the baseline activity within 60 minutes of seizure medication. Next one, please. At the end, I would like to remind to myself that, of course, each of these monitoring, as I tried to quickly explain, can give us information of a particular aspect of brain physiology, for example, cerebral blood flow or brain metabolism or brain oxygenation. If we can have the possibility to put together all this information, of course, the overall picture of the patient will be much more interesting and more useful for the clinician. And as you can see in the next picture, we can have the possibility to use some platforms which will integrate all these different systems and can give us a better picture that will allow a better monitoring of the patient. Next, please. And as you can see here, the same guidelines recommendation suggest the use of a display that can help the clinician not to be confused with all the information, but to use an integrated system that can integrate different data from the different monitoring systems. And at the very end, the next slide that will be my last one, I would like to remind myself which is the most important aim target for the use of neuromonitoring tools in the patient with acute brain injury. So why can we use and should we use this monitoring? We can use and we should use some monitoring that we saw during this presentation, because this monitoring can give us an early warning of a secondary cerebral deterioration, giving us the possibility to use targeted therapy when we are still in time to do something that can avoid irreversible brain damage. So the reasoning for using neuromonitoring, first of all, to detect secondary insult and clarify the mechanism of injury. Then, as we saw, neuromonitoring can give us a lot of important information to study and to understand cerebral energy metabolism, which is in crisis after acute brain injuries. And then, as we saw during some clinical intervention, we can have some very important informations on the effect of some drugs or some intervention on brain physiology. And so this monitoring tool, on the one side, they can help the clinician in the daily activity, but they can also help the researcher during the different studies, experimental and also clinical study, to better study the pathomechanism of injury and to better study neuroprotective therapies. Thank you so much for this invitation, and I hope I was able to give just some basic information of a very important topic in acute brain injury. Thank you.
Great, Anne. I really appreciate your effort to connect with us, to give the neurosurgical community, the Asian Congress of Neurosurgery Society, and the followers one aspect of care of traumatic brain injury. And like you said at the end, I think with the with the effective use of computers and big data to make algorithms, to make it simple for physicians like me and for neurosurgeons that really probably don't spend too much time studying neuromonitoring, a method of better dealing with traumatic brain injury. So I really appreciate it. This is recorded, and this hopefully will be part of your future in talking to neurosurgeons around the world, because we want to basically use this platform to reach many people in the ways of communication, the best ways of communication we can. Just like you analyze machines to analyze things, we want to use machines to educate, basically, in topics that you're talking about, to give physicians that don't have a chance to go to a conference, that are too busy, and that need to learn things like what you put a heck of a lot of work into that presentation. You've done a lot of research, right?
I have done a lot of research, especially while I was working at MCV with Dr. Ross Bullock, and I am continuing also doing this kind of research right now at the University of Turin. That is my actual position in Italy.
Oh,
yes.
Okay. So are you a practicing intensivist, or do you basically do research?
I do both things because I work in the ICU, and I am also part of the university with the position of assistant professor of anesthesia and intensive care. So I need to dedicate part of my work to research and part to clinical activity. And as you know, the best way is to integrate both things.
Yes, it is.
The results.
And I'd like to ask one favor of you, Anne.
Yes.
I want you to tell the first two Americans you run into that it's good luck to swim in the canals.
No, it is not possible to swim in the canals, especially if you have to give a lecture.
Okay, Anne. I'll email you the copy of the address of this talk, but thank you very much.
Thank you very much. Thank you.
Bye-bye.
Thank you.